FB is streaming.
Hi. Yes, I have to.
Yes, ma'am, we are live now.
Good evening, everyone. Myself, Raja Rajeshwari, Product Manager from Emcure Pharma. I take the privilege to welcome all the delegates for this wonderful meeting. So currently we have the preventive care, live webinar on preventive care in obstetrics and gynec practice. We have with us our chief guest, Dr. Jaydeep Malhotra, Dr. Lakshmi, and Dr. Yashodhara Pradeep, madam, with us. So with this note, let me start the presentation. So I welcome you all once again for this wonderful live webinar. So on behalf of OGSSI, we welcome you all for the live webinar. The welcome address will be by Dr. Jairani Kamraj, and we have the prayer followed by the presentation on preventive care to improve obstetric outcomes by Dr. Manoj, and then we have the topic on steps to prevent infertility and facts to improve infertility by Dr. Sunita Tandulwalkar, and we have next topic on preventive steps to prevent cancer in women by Dr. Priya Ganesh Kumar, and finally vote of thanks by Dr. Kalevani. So this is how the flow of the presentation agenda goes on. So with this note, let's start our webinar with the Tamil Thai Valtu.
Audio is not there, Rajeshwari. Audio is not there.
1 second.
Ma'am,
கடலுடுத்த நிலமடந்தை கெழிலொழுகும் சீராரும் மதனமென திகழ்வரத கண்டமிதில் எக்கணமும் அதில் சிறந்த திராவிடனல் திருநாடும் தக்க சிறு திரை முதலும் தரித்தனரும் திலகமுமே திலக வாசனை போல் அனைத்துலகும் இன்பமுற எத்திசையும் புகழ் மணக்க இருந்த பெரும் தமிழனங்கே தமிழனங்கே உன் சீரிழமை திறம் வியந்து செயல் மறந்து வாழ்த்துதுமே வாழ்த்துதுமே வாழ்த்துதுமே.
So let's start this auspicious occasion with lighting the lamp. So with this note, let me introduce the women behind the program, Dr. K.S. Jairamani Kamaraj. Ma'am Ma'am is the director of Akash Fertility Center and Hospital based out at Vadapalani, Chennai. Ma'am has been associated with various organizations. She is the associate secretary of World Association for Sexual Health and advisory council member of World Association for Sexual Health. And she is the president of OGSSI, treasurer of TAP ISAR, and joining organizing secretary of ISAR. Ma'am has got so much of medals and rewards and recognition. She has got the best doctor award by Dr. MGR University, Chennai, and ma'am has won Dr. Vadamalayan Endowment Gold Medalist in MBBS Obstetrics and Gynecology examination, and she has been awarded as the Women of the Year in 2010 by Lions Club, and she is the Mega TV Women Achiever Award in 2011. And she also runs Nalam Hospital, for which she has won the Women Achiever Award in 2011. And she has been awarded as the best paper in sexual dysfunction, especially in PCOS infertile women. So I would like to hand over the session to Dr. Jairani Kamraj, ma'am. Thank you so much.
Thank you, Rajeshwari. அனைவருக்கும் வணக்கம். Good evening, one and all. Respected chief guest of this webinar, my dear Dr. Jaideep Malhotra, madam. It has been a great pleasure to have you with us. And we start our first webinar now with your blessing. And I'm very happy and honored to have you. And in midst of all your work, you have accepted to join the webinar. It is a great pleasure, ma'am. On behalf of Oxy, and a very pleasant way, I would like to welcome you and thanks for accepting our invite. A respected Lakshmi, madam, who is a best friend of mine, who is the chairperson of ICOG. Thank you, madam, for joining us to be the guest of honor for this webinar of Oxy. And very special thanks and welcome to Dr. Yashodhara Pradeep, ma'am, President Foxy, for accepting for invite to be the guest of honor. And my dear Honorary Secretary, Dr. Kundavi, and chairpersons and the eminent speakers, Dr. Manoj Chalani, who is the chairperson of the Foxy Medical Disorders in Pregnancy, and Dr. Priya, who is the chairperson of Foxy Gynecological Oncology Cancer Committee, and Dr. Sunita Tandulwakar, who is a chairperson of the IAG and a past vice president. We have the elite, eminent, and very knowledgeable speakers here to talk on preventive obstetric and gynec care, because we all know prevention is better than a cure. It is always better to be safe than to be sad or sorrowful. And we as presently living in a world where there is a prevention seems to be the best care that we can give it to the medical faculty. In that way, we as an obstetrician and gynecologist, we would like to have the knowledge shared about the practical tips to prevent this various conditions in this obstetric and gynec practice. For this, we have all the three eminent speakers to speak on this, and we have the very eminent and senior faculties to chair the session. I have the great pleasure to welcome Dr. Satish Dhanashankar sir, the president of Welcome OB/GYN Society, Dr. Manju Singh, the secretary of the Bharatpur OB/GYN Society, Dr. Kamini Patel, the president of the Ahmedabad Society, and Dr. Rajal Thakkar, the past president of Ahmedabad OB/GYN Society, Dr. Radha Dattapari, the past president of Vizag OB/GYN Society, and my dear Dr. Premlata, who is the past president of Oxy. With all these eminent and elite faculties and my dear delegates who have joined with us, I have the great pleasure to have this webinar on preventive care in obstetrics and gynec practice. To start with, we would like to have our chief guest, Madam Dr. Jaideep Malhotra. Can I have Madam CV? Madam is the Managing Director of the ART Center, Rainbow IVF Center, who is the Professor of the Dubrovnik International University of Croatia. And Madam is the President Oxy 2018, which has done a lot of dynamic work for the womenhood. And we are really proud to have her here. And she's the present President-elect of SAOMS, and she's the President-elect of ISPAT. She was the Vice President of ESAR and the past President of Aspire, IMS, and very many credentials she has in her credit. and she was the regional director of the Iron Donald School of Prussia, and she's the editor of Suffolk Journal and Suffolk MS Journal, and she's the editor and co-editor of several books.
Yeah, it's okay.
Oh,
It's okay, Jaya.
here is Neema.
Over to you, madam. Over to madam.
Thank you so much, Jaya. It's really, it feels so good that you are not really now sitting on any chair and people invite you and, they shower all love and affection. I can't even explain the kind of feeling it gives. And it's only has to be felt to be believed. And I feel I'm very, very privileged to, get so much love from each and every one of you. Today, I'm feeling absolutely proud because you have chosen a subject which is very, very close to my heart, because I'm sure each one of us in the medical profession, we understand prevention is better than cure, but we actually do not know from where we should start. And if we are looking at, how the kind of thought process which I lived with, and this prevention has to start from the womb itself, because today we are, especially in India, the diabetic capital of the world. We are the obesity capital of the world. We have, very rising trend of non-communicable diseases and the cardiac disease. And the cardiac diseases are coming in our country 10 years earlier than the West. We are also the preterm birth capital of the world. So, and all of this has, the foundation somewhere, because today, if we do not look into it in depth, I don't think we are going to be able to prevent or even think of curing anything, because if the foundations are so deep ingrown, how can you really go ahead and then eradicate? So these three subjects which you have chosen with the wonderful, wonderful speakers, I'm sure they're going to do a lot of justice to it. But more than that, I would say that all of us are gynecs. We are really privileged because we come in connection with the lady for more than a year and sometimes for a lifetime, because when she is pregnant, 9 months plus minus, she is there with us. She'll come back for the second child, and the amount of change in her thought process which we can bring about is phenomenal. And I think each one of us should definitely be investing in it. And I cannot help but talk about the iMoms app, because that's another very important aspect which is dealing with the same subject which you have chosen. Because we say the foundation of all disease, disability, and personality is laid down in the womb of the mother. So if we are really going to be able to help her, we need a lot of time to make each and every one educate, and that's not possible for any one of us. We are only 100,000 gynecologists, and we have more than 40 million births in our country. We cannot do justice. So we have to be savvy, we have to be smart, and we have to use technology to the best of our advantage. And this app is there for each one of you to prescribe to your patients, because it's free. And anyone who wants a little more information, which we may not be able to give, is all freely available on the app. And what more can I say, that this app has won the Pradhan Mantri's Atmanirbhar App Challenge. It is on the 10 most innovative apps on the Google Play Store. And very recently, if you have seen, Shark Tanks also has invested in us. Now, everyone else can invest. But if my own fraternity, my own gynecologists do not invest in the promotion of this app, I don't think we can prevent any disease, any disability, and personality disorders. So I would really urge all of you and request all of you that, yes, do your best, whatever knowledge we have, to prevent whatever we can, whether it is maternal obstetric or infertility or malignancies, which are really on the rise. But yes, that prevention has to start from the womb itself. Another very important aspect which we should not lose track of is that environmental factors play a lot of role. So we also ourselves also have to be role models, because they also have a lot of effect on the increasing trends of all these diseases which we are really looking forward to. So fantastic job, Jaya. This is really, really phenomenal, and I wish we'll have many more of these so that we can reach out to each and every doctor and each and every woman in our country, so that we are able to prevent these majority of the issues in the times to come. And I would really congratulate the guest of honors, both Lakshmi and Yashodhara, and the fantastic speakers, Sunita, Manoj, and Priya. All of them are very, very close to me, and I'm sure they're going to do a great job. And I'm here going to be sitting and listening to all of you. Thank you so much for having me here. God
Thank
bless
you,
you.
madam. Thank you, madam. Thank you for this wonderful, encouraging, inspirational talk for all of us, which is a real thing that we all should adapt in our practice, and we are obliged to do for the knowledge about the apps, very much important in our clinical practice. Thank you, ma'am. Thank you for your nice words. And I have the great pleasure and honor to introduce the guest of honor, Dr. Lakshmi. Can I have Madam Stevie? Raji?
I'm sharing.
Yeah. All of us know Lakshmi for her dynamic effect. Madam is the ICOG chairperson from the Indian College of OBGYN. She is the corresponding editor journal of OBGYN of Jogi, and she's the national corresponding secretary, Association of Medical Women in India. And she's the founder, patron, and president of ISOBAB Without Chapter 2019 and 21. She is the chairperson of IMS Education Committee between sitting 2021 to 23. And she's the president, Association of Medical Women of Nagpur between 21 to 24. And she is the achiever of the Nagarpur Ratan Award from the hand of Union Minister Shri Nitin G. Gadari. And she is the receiver of Mehru Dara Hanasotia Best Committee Award for her work as chairperson of HIV and AIDS Committee in Foxy between 2007 and 2009. She had received a lot of appreciation letter from Maharashtra government for her excellent work in the field of Save the Girl Child. And she's the senior vice president of Foxy 2012. And she was the president of Menopause Society of Nagpur between 2016 and 18. President of Nagpur OBGYN Society between 2005 and 6. And she has delivered 11 orations and 450 guest lectures and published nearly around 30 in all national, 11 international journals. And she has sensitized nearly 2 lakhs of boys and girls on adolescent sexual health issues. Definitely, madam, you are a great person to be a chairperson of the ICOG of Indian OBGYN, Indian College of OBGYN, and we are great to have you here. On behalf of OPSI, I welcome you and to deliver your guest of honor felicitation.
Thank you. Thank you so much, Jaya, for your kind words, your love, affection, and the topic, the theme you have chosen for today's webinar is very apt theme, that is prevention in OBGYN. As you already said, prevention is better than cure, because we all know it is. And as our chief guest was saying, that prevention starts from the womb. So yes, it starts from the womb, but whenever any woman comes to us, all 3 aspects, obstetrics, gynecology, and infertility, it starts with us, because we are the gynecologist obstetrician. As Dr. Jaideep Malhotra has already said, we come into their contact for so many years of their life that we can really influence her thought process as far as prevention is concerned. When it comes to prevention in cancer, yes, we can change her thought process as far as pap smear, self-breast examination, and HPV vaccination is concerned. Up to 45 years, she is eligible, but in and around her area, wherever she is working, she can really promote HPV vaccination if she is convinced. And plus regular checkup as far as gynec cancers are concerned. When it comes to obstetrics, we all know that it plays a great role. Preconception counseling, as Dr. Jaideep Malhotra has already said, her iMoms app, and the phenomenal work they are doing towards preventive aspect in obstetrics, that Garbha Sanskar, those preconception counseling, that really makes a lot of difference as far as obstetric outcome for both mother and neonate is concerned. And what to say about infertility, because I'm infertility specialist. If we can really change the thought process of the society that every girl should have at least one child before the age of 30 years, which nowadays looks a very, very distant dream, with all these girls becoming financially independent, they want to have a car, a house, and a substantial position in their career. They are just not thinking of pregnancy. But when it comes to infertility, definitely this will also go a long, long way as far as prevention of subfertility is concerned. And as you and our chief guest has already said, not only OBGY, each and every aspect of every human being, we can really prevent lot many diseases, whether it is cardiovascular health, her bone health, and whatnot. So prevention, I'm so happy that you are Oxy and you have come out with this theme of preventive care in obstetrics and gynecology. And I'm sure it will go a long way in helping us to reduce maternal and neonatal mortality and morbidity both. So I wish you all the success in this for this webinar. And thank you once again for inviting me and making me a part of this lovely, lovely webinar. Thank you, Jaya.
Thank you, Madam. Thank you, Madam Lakshmi, for that lovely words. And it's really a very great thing to have you here in midst of our many commitments to be with us, to give our felicitation to us, to have a very good presence of yours to grace this occasion. Thank you, Madam. Thank you for being with us. I have the great honor and present. Yashodhara Madam has logged in. I said I
Can't see her.
I know. So Kundabai, can we have the Oxy prayer? As I'll call up Madam to check whether she's here. You can just go ahead with Oxy prayer. And then before we start the scientific session, let me check whether Madam is here. If so, I will just call her to log in.
Thanks for the invite. Yeah. Thank you, God. In humility we gather. In gratitude we pray for all the good things you have given us. Shower us with your blessings to pass on the healing touch, to celebrate the arrival of each new life and a mom reborn. The courage to deal with it all when things are not perfect, and to remember that we are but the messengers to keep our women safe and free from sorrow. We bow before your kindness and the magnanimity of your endless love. Thank you. Rajiv, can we move on to the next slide?
So Madam will be logging in now. So we have the great pleasure and honor to have with us the President Foxy, Vice President Foxy, Dr. Yashodhara Pradeep. She's a retired professor and HOD of Lucknow, Dr. RML LMS in Lucknow in 2021. Was an earlier senior professor of King George Medical University. She has 35 years of clinical teaching and experience, a postgraduate teacher and examiner to many national and international universities. She has conducted a lot of certificate courses on contraception, EMOC, BMOC, CTU for medical officers. She has delivered more than 200 guest lectures and contributed many book chapters, and is currently a reviewer of Journal of Midlife Health. And she has more than 100 publications to her credit. And she is the president of Lucknow OBGYN Society and the president-elect of Vice President-elect of Foxy. She was a chairperson of Family Welfare Committee between 2016 and 2018 in Foxy, and is very passionate about women's empowerment and contraception. Madam is here. She said that she's logging in.
Can we move ahead?
Madam will be logging in. Once she's logging in, we will call her again. I think, Kudve, can we go ahead with the academic?
Slide. Yeah,
Yeah, over to you.
Raji,
The chairperson. Once Madam logged in, we will call her again to deliver her.
can I have the chairperson's CV, please? Yeah. I invite we invite Dr. Radha Tattapadi. She's an organizing chairperson, Yuva Foxy South Zone, past president, OGS Visakhapatnam, Andhra Pradesh, member Society Board, National Board of Examinations, New Delhi, formerly principal of Andhra Medical College, Visakhapatnam. I'm emeritus professor of OBG, Andhra Medical College, and professor and HOD of GIMSR, Geetham, deemed to be university, and occupied executive positions in OGSV and AP State Society, delivered lectures in national and state conferences, outstanding research award in ISSHP 2012, Geneva, and her field of interest is preeclampsia, eclampsia, and medical disorders. She's edited book of obstetric emergencies, intrapartum care, and obstetric gynecological update. The next chairperson. Next slide. Dr. Manju.
Kudve, can we have yeah, you can introduce Dr. Rajal Thakkar. Can you introduce her? Madam wants to leave earlier. So
Okay.
you can put that, yeah. You can introduce the chairperson, Dr. Rajal Thakkar.
Dr. Raj,
Dr. Rajal. The previous one. Yeah, that one. Next one. Next one. Next one. Next one. No, next one. Yeah.
Dr. Rajal Thakur is past president, Ahmedabad OB Society, national coordinator, Adolescent Health Committee, Foxy, professor of NHL Municipal Medical College, ACL Ahmedabad. She's got a special interest in adolescent health, working for an adolescent health for the last several years, covered more than 1 lakh adolescents, girls and boys during the tribal groups, and one of the selected candidates for training in adolescent, member adolescent
Yes,
health
madam,
committee.
few lines, please.
Yes,
That's
madam.
okay.
Yes, madam.
Thank you.
Over
Yes,
to you,
yes.
madam. Over to you, madam.
Ma'am, it's really a great honor to have you, ma'am, because you have covered more than 1 lakh adolescents in the tribal areas, which is a real credit of your services, which we really appreciate and admire, ma'am. So my admiration for you is only this when I saw your CV, and really I'm pleasure to have you here, ma'am. Very special thanks for being with us.
Thank you so much for inviting, and vanakkam.
Oh, yes, ma'am. Thank you, ma'am.
So I pronounced it right.
Yeah, you're very correct, ma'am. Perfect, Tamil.
Thanks very much for inviting, and it's good to reconnect you all. And with this, I need to introduce Dr. Chelani, sir.
Yeah.
Yeah, so please give me the share the CV.
Raji, Dr. Chelani, Manju Chelani with a CV. Yeah.
A very good evening to all who have joined our webinar across India and OG Society of Southern India faculty. Dr. Manoj Chelani is a very senior consultant, director of Ayush Hospital and Test Center, Raipur. Currently, he is a chairperson of Medical Disorders in Pregnancy Committee of Foxy, past president of Raipur OBGYN Society, organizing secretary of North Zone Yuva Foxy, chairperson elect for CGISR 2023-25, chairperson of Urogynecology Committee of Indian Menopause Society, founder chairperson of IAG CG Committee, founder chairperson and secretary of IFS, vice president of ISOPAR, vice president Chhattisgarh IMA, and awarded by Chief Minister of Chhattisgarh, and many other accolades on his credit. Over to you, Manoj Chelani, sir, for your talk on the preventive obstetrics.
Can I say a few words?
Yes.
This is Dr. Radha.
Yes, go ahead.
Yeah, I thank Dr. Jairani and Dr. Kundavi and her team for giving me the opportunity to participate in the webinar as a chairperson.
டிவி ஒளிபரப்பான சன் நெக்ஸ்டில் பாருங்க. இந்திய பயனாளர்களுக்கு முற்றிலும் இலவசம். இப்போதே ஆப்பை டவுன்லோட் செய்யுங்கள்.
Can we start with Chelani, sir?
So, Chelani sir, can you share
Yeah.
your presentation, sir?
Yeah, thank you, Rahul ma'am, for introduction, and thank you, Jairani ma'am, for giving me this opportunity. And
Yeah. Can I continue?
Yeah.
Yeah.
Madam. Yes, madam.
Yeah,
Yeah.
this preventive care, this applies to every field of medicine, including obstetrics. But prevention in obstetrics requires a planned pregnancy, pre-pregnancy counseling and evaluation. And this is to maintain maternal and fetal health during pregnancy, as well as long-term health of the women and offspring. This may be in the form of vaccinations, nutrition, diagnosis and alteration of medication in illnesses such as diabetes, hypertension and renal disease before pregnancy, or prevention of certain diseases like preeclampsia and other diseases during pregnancy. So anticipation and prevention of intrapartum complications is also important. I invite Dr. Manoj Chelani to enlighten us on the scope of preventive care in obstetrics. Thank you.
thank you, Radha ma'am, for the wonderful start. So, like we have moved a lot from ASHA workers to now app.
Excuse
The
me, sir.
Ayushman app
Excuse
is
me,
there.
sir.
So,
Excuse me, sir. Please, all other mute yourself, because mute yourself except sir, because it is disturbing others. Rajesh, if you have any option to mute all the faculty others,
I just
kindly.
spoke with the coordinator, ma'am. They are muting.
Please.
Just
Thank you, sir. Thank you, sir. Thank you.
So we have moved a long way from ASHA workers to now app. The IMAM app is there with us. Thanks to Dr. Jaideep Malhotra ma'am for introducing those apps for women in India. So we have a diversity of population. We have a rural population, we have a urban population, we have a educated population, we have educated population. So it's the problem, but problem with everyone is same. It's our duty to take care of them, to do the preventive, to take the preventive measures to have a good obstetric outcome. Recently, our president had this yatra from Rishikesh to Calcutta, and that was for the sake of prevention of anemia Bachao Yatra, and all like a lot of screening work was done to all the cities, and a lot of talks were there, panel discussions were there, public forums were there. So screening, this prevention plays a very, very important role in obstetric care, because when we invest more in prevention, we have to less invest in the complications, and outcomes are much, much better for our patients. So I thank all my guests, Dr. Jaideep Malhotra ma'am, Dr. Lakshmi Shikhande ma'am, and my fellow speakers, Dr. Sujata Anwar ma'am. Just a minute. Yeah. So, applying existing effective 3 E's, that is early screening, essential obstetric services, emergency obstetric care, and improving access to good quality health services by pregnant women. That should be our goal. So early screening, there has to be early registration. The patient should register early to her obstetrician for the prevention care cycle to detect high-risk cases. There has to be essential obstetric care. Provision of minimum 3 antenatal checkups should be there, and management of women at high risk, maybe for anemia prevention or hemorrhagic prevention or prevention of infections. Prevention of medical complications like hypertension, diabetes mellitus, tuberculosis, malaria, and viral hepatitis, and there has to be prevention of HIV and STD. Then there has to be a prevention of prolonged labor, obstructive labor, and provision of safe delivery. There has to be clean practices, there has to be trained diet, there has to be community level skilled birth attendance. So it's a holistic approach should be there. It's teamwork. So right from the DICE, the ASHA workers at the village level to the consultant or to the head of department at the medical college level or at the consultant at the corporate hospital, we all have a very, very important role in prevention. So first, prevention starts with the assessment, physical assessment, including physical examination, medical and family history, the career screening, Immunization record including rubella, hepatitis, and varicella. Complication with past pregnancies. We have to take a proper history, whether if there was a complication with past pregnancies, such as postpartum hemorrhage, thrombotic events, preeclampsia, eclampsia, PIH, gestational diabetes, or there was RH incompatibility. And we have to identify and assist for victims of domestic violence. This is also very, very important. Our last president's theme was violence against women. So that is very, very important. The FOXI has also realized the importance of this, and we are really paying a lot of attention to these things. And psychology counseling for parent readiness is also there. Alcohol, it is really a menace these days. Youngsters, young girls are now moving more into alcoholism and smoking. So now the women, the women of reproductive age groups we have to really take a proper history, and we have to really counsel them to abstain from alcoholism, because it is preventable cause of birth defects, including mental retardation and neurodevelopment defect. And it's recommended that women are counseled preconceptually about these effects. Domestic violence, as I already said, that is very important. Trauma, either accidental or intentional, is a leading cause of death in women of reproductive age. Violence often begins during pregnancy, and if it is already present, it may escalate and continue throughout the postpartum period. Screening women at once in each MSA recommended whenever bruising, improbable injury, or depressed mood is noted. So it's very important for us to just looking at her, by talking to her, we should be able to judge whether she is going under some problem at home. We should give her confidence, and so that she speaks out to us, and then we involve all the family members and try to solve the issue. Drug abuse is also a very, very big problem, and we should always try to help her for drug de-addiction. Folic acid neutral tube defects such as anencephaly and spina bifida have multifactorial origins, but their etiology often may involve abnormalities in homocysteine metabolism that are potentially remediable by folic acid dietary supplementation. So only 0.4 milligram of folic acid can prevent so much. So this is very, very important. We should take proper history from the women about the prior pregnancy loss. Preconception counseling is recommended in women who experience a prior pregnancy loss. During the preconception period, investigate the factors that may have contributed to the previous negative outcomes and attempt to assert guilt and help patients resolve any grief from a previous loss. It's very important that we really understand her psychological status and emotional status, and we try to find out what was the cause of her previous losses. Again, the psychological concerns should be there, and we have to do the risk assessment of if there's a barrier to care, unstable housing, unintended pregnancy, communication barrier, nutrition, tobacco use, substance use, depression, safety, intimate partner violence, and stress. So spending time with the patient is very, very important. Smoking, we have already discussed. Now come to chronic diseases. It's very important to look for the chronic diseases, and which may exacerbate during pregnancy, or pregnancy may exacerbate them, or vice versa. So asthma during pregnancy requires special attention and comprehensive treatment. Alteration of doses for certain medications such as corticosteroids may change. Educating patients preconceptually would be beneficial to the patient's pregnancy outcome. Additionally, environmental factors such as allergens, that's animal dander, house dust, mites, cockroaches, pollen, indoor mold. Most of our women are from the rural background. They are farmers. So it's very, very important to counsel them, to know where they are working, and to tell them to prevent themselves from the exacerbation of asthma during her pregnancy period. And about tobacco, smoke, indoor and outdoor pollutants, they are most of our urban rural women, they are using the wood stove or fireplace to cook their food. To advise them to abstain from that, and could exacerbate asthma attacks, and should be discussed during preconception to limit exposure. Diabetes is very, very important. As soon as possible, the screening, as soon as the pregnant patient comes and she comes to you for the visit, please screen her for the diabetes. Once it's have been proven that universal screening is better than a selective screening. And now you can just patient when it comes to you, whether she is fasting or not, you do her give her 75 milligram of glucose with 300 ml of water and check her blood glucose level after 2 hours. So that is very, very important. Screening of diabetes is very important. Heart diseases. Now, post-COVID, I've seen a lot of lot of cases who were normal initially, but during pregnancy, there are various issues with the heart diseases. So screening of heart disease are very, very important. Take proper history from the patient. And women of reproductive age living with heart disease should be counseled about the potential risks associated with pregnancy, hypertension in pregnancy, specifically preeclampsia and transient hypertension of pregnancy is associated with increased rate of hypertension and coronary heart disease later in life. Hypothyroidism. Women should be counseled pre-conception about treatment during pregnancy. Treatment of hypothyroidism in pregnant women is the same as for non-pregnant women and involves administering levothyroxine at sufficient dosage to normalize thyroid stimulating hormone levels. Levothyroxine therapy should be adjusted at 4 weeks interval until TSH levels are stable. Obesity. Obstetrician should provide pre-conceptual counseling and education about the possible complication and should encourage obese patients to undertake a weight reduction program before attempting pregnancy. So even modest reduction in weight may have a beneficial effect in perinatal outcome. During pregnancy, weight reduction is not advisable, but counseling concerning appropriate weight gain is advisable. So little bit of light diet, a little bit of exercise will go a long way in helping her to maintain her weight, not to go excess, not to gain excess of weight. So that is very, very important. Diet is a very, very important factor in pregnancy so that she gets the proper nutrition. And on the same hand, she should not increase her weight. So that is very, very important. Oral health is also important. Dental care is encouraged as appropriate before and during pregnancy. Some studies have found an association between periodontal disease and poor pregnancy outcome of premature delivery, low birth weight, and preeclampsia. Genetics. When we talk about cystic like disease like cystic fibrosis, preconception carrier screening for CF allows carrier couples to consider all reproductive outcomes. The decision to have CF carrier screening should be with the patient informed consent. CF carrier screening should be offered before conception or early in pregnancy when both an individual with a family history of CF medical records of the affected family member should be obtained. When both partners are CF carriers, genetic counseling is recommended to review reproductive options. Then there's maternal phenylketonuria, routine screening of PKU in newborns, and early dietary therapy with a phenylalanine restricted diet have markedly reduced mental retardation in affected individuals. It has been suggested that dietary control should be implemented at least 3 months prior to conception to help prevent fetal structural defects, cardiac defects, low birth rates, microcephaly, and mental retardation. Sickle cell anemia is very prevalent, especially in my country, in Chhattisgarh and in adjoining areas of Chhattisgarh. Pregnancy in women with sickle cell disease is associated with increased risk of morbidity and mortality because of combination of underlying hemolytic anemia and multi-organ dysfunction associated with this disorder. Pregnant women with sickle cell disease need increased prenatal folic acid supplementation. A recommended 4 milligram per day of folic acid should be prescribed due to continued turnover of red blood cell. A complete blood count and hemoglobin electrophoresis are the appropriate laboratory tests for screening of hemoglobinopathies. Solubility tests alone are inadequate for screening because they fail to identify important transmissible hemoglobin gene abnormalities affecting fetal outcome. Couple at risk for having a child with sickle cell disease or thalassemia should be offered genetic counseling to review prenatal testing and reproductive options. Prenatal diagnosis of hemoglobinopathies is best accompanied by DNA analysis of cultural amniocentesis or chorionic villi. So this we should offer to the sickling patient. When the government has in the Pradhan Mantri Swasthya Abhiyan and the Ayushman Yojana, they are promoting, they are financing these tests, and this should be encouraged and this should be done. Now, important is medication. Proper history of medication is very important. What kind of medication she's taking, whether those medicines are harmful during her pregnancy should be counseled, and that those medicines should be discontinued if it doesn't affect her existing problems. So medication should be continued to control disease in women during the preconception period. And switching medication may be appropriate during the preconception period if suitable alternatives exist with less risk to the pregnant woman or fetus. Certain drugs taken preconception may be at risk for negative pregnancy outcome. Some examples of drugs which should be managed carefully during the preconception periods are isotretinoins. If used in pregnancy to treat acne, it can result in miscarriage and birth defects. And pregnancy prevention should be practiced in women of reproductive age taking these drugs. Anti-epileptic drugs, certain types of these drugs are teratogens like valproic acid. Oral anticoagulants drugs for management of blood clotting such as warfarin have shown to be teratogenic. Early exposure during pregnancy could be avoided preconceptually by switching drugs. Now we have to really look after the sexually transmitted infections. STIs can have a harmful effect on pregnant women, their partners, and their fetuses. And all women of reproductive age and their sex partners should be asked about STIs, counseled about the possibility of perinatal infection during pregnancy, and given access to treatment if needed, preconceptually and during pregnancy. And I'm glad Dr. Jairani is here. She is a lot into the sexual medicine, and she's doing a lot of work in this area. We also screen for bacterial vaginosis. Evaluation for BV might be conducted during the first prenatal visit for asymptomatic patients who are at risk for preterm labor. Example, those who have a history of previous preterm delivery. Chlamydia, all pregnant women should be routinely tested for chlamydia trachomatis at the first prenatal visit. Gonorrhea, all pregnant women at risk for gonorrhea or living in an area in which the prevalence of Neisseria gonorrhea is high should be tested at the first prenatal visit for Neisseria gonorrhea. A repeat test should be performed during the third trimester for those at continuous risk. Hepatitis B, hepatitis C, and HIV. All these three tests should be done, and patients should be screening. Cervical cytology should be obtained at the first prenatal visit, and for syphilis, a serological test should be performed in all pregnant women. Now, vaccination is very, very important. HPV vaccine, still there's a controversy that it's not recommended at this time. Influenza vaccine should be given during the months of October and November. I mean, when and the theoretical risk of vaccination is outweighed by its benefit. Likewise, the benefit of the vaccine outweighs any unproven potential concern about the traces of trimester preservatives. So, the influenza vaccine should be given to the patient. Rubella seronegativity, the rubella vaccine is live attenuated virus, and there is few side effects in rubella susceptible women of reproductive age. Rubella vaccination is not recommended during pregnancy. Women should be advised to avoid consumption for 1 month following immunization. So this is very, very important. Additionally, this vaccine should be administered to all susceptible women pre-conception. And varicella vaccine, the risk involved for the pregnant women who contract varicella include an increased chance of developing severe pneumonia. Risk for the fetus include congenital varicella, and live virus vaccine during pregnancy is contraindicated for varicella vaccination, but no adverse outcome have been reported during pregnancy. Now, genetic care, we have already discussed. The folic acid supplementation should be given. The counseling of sickle cell, CF, thalassemia should be done. Counseling for HIV, syphilis, gonorrhea should be done. We should promote smoking cessation, screen for alcoholism. Then we have to also take the history of whether there is occupational exposure to any harmful substances, and as well as in the household chemicals like paints, thinners, strippers, and other solvent pesticide. And we have to also ask the patient to avoid radiation exposure. Medical assessment, evaluate overall health and opportunities for improving health. Determine if a woman suffers from any undiagnosed or uncontrolled medical problem, example, diabetes, thyroid disease, dental caries, gum disease, heart disease, or asthma. In case of diabetes, do the optimize the control. Hypertension, avoid ACE inhibitors, angiotensin II receptor antagonists. In case of epilepsy, consider increased dose of folic acid. In DVT, switch from warfarin to heparin. In acne, stop isotretinoins, and that is Accutane. And in case of depression, anxiety, and other mental health issues, discuss current benefit risk medication data. So this is very, very important, especially in case of depression, anxiety. Sometimes we are unable to, keep the patient off these drugs, but then we have to weigh the risk as well as benefit is concerned. Lifestyle modification is very, very important. We have to promote regular moderate exercise, avoid hyperthermia, caution against obesity and being underweight, assess risk of nutrient deficiencies, whether she's vegan, she's having pica, if there's a milk intolerance or calcium or iron deficiency. And one more thing is important is she has to avoid overuse of vitamins. Vitamin A, we know the limit is up to 3,000 international unit, and in vitamin D, the limit is to 400 international unit. And caffeine also she should be advised to take less amount of caffeine and less amount of soda. So we have already discussed about the domestic violence and screening. So assess any complication from previous pregnancies, from cesarean delivery or premature delivery, diabetes, and DVT or PE. And there are various other programs are available, and there new initiatives have been taken. The government is also involved. There is Janani Suraksha Yojana is also there. Then there's a Vande Mataram scheme is there. Chiranjeevi Yojana, which is very popular in Gujarat, which Dr. Adil Madam will tell us more about it. And there's a structural adjustment program is there, where the hospitals for complicated deliveries and pregnancies are there. There has to be a transport. There has to be a trained personnel. So at the end, I would like to let you know the checklist for preconception care, education, then smoking, alcohol abuse, and other drug use. We have to take proper history and abstinence, folic acid supplementation, counseling about the sexually transmitted disease and HIV infection, family planning and pregnancy spacing, healthy body weight and diet, importance of oral health, increased risk of hepatitis C, those with tattoos or body piercing. So we have to look into that and other things. And thank you very much for your patient listening. And here I would also like to tell you about the importance of anti-scanning and other markers, quadruple markers, and about the detailed anomaly scan. So these all things are very, very important. We have to make sure that in each trimester, at least once she visits to your place, and proper history and this thing is there. So thank you very much for your patience. Thank you.
Thank you very much, Dr. Chelani, sir, for your elaborate discussion on the preventive aspects. And I just want to add a few lines regarding the maternal death. The direct and the indirect one, we all know. So we have tried to, to decrease the, like I am working at a tertiary care medical college hospital. So over the years, what we have seen is like direct causes are decreasing. Maybe the PPH we are taking so much precaution, and then people are aware of it. Doctors are, even eclampsia, they report early. But then at the same time, indirect causes are rising. May it be an infection, may it be a hepatitis or the other causes. So we need to check for this indirect causes, and that is not only it's our role, it is the government and our system's role is also, because if there is malaria, patient is going to get infected. If there is hepatitis, patient is going to, so all sorts of environmental issues to be taken care of. And at the same time, not only the doctors, but the community needs to be aware. When we see the delays, there is always a first delay at the community level, at the level of the patient. They will come late. Today only we had a patient of previous 2 CS. Both the children are very, healthy condition, and patient is having 6 grams of hemoglobin. And then we need to give all transfusions, but at the same time, all complications can happen. But then patients are not aware of the complications that may happen because they are taking it so lightly. So we need to create much awareness at the Foxy level, at the local level, and at the personal level, so that the community remains aware. And for that also, the education of girl child is also very, very important. Once she is educated, when she gets married at the right age, so the community level, the nutrition problems are taken care of, anemia is taken care of, so that we get less number of anemic patients. The education is good, so that the patient herself can report to any symptoms that she is having. And not only the maternal mortality, maternal near miss cases are also very, very important, because mortality is the tip of the iceberg. Near miss cases are also on rise, so we need to take care of that. And beti padhao or bete ko bhi samjhao, so that we can prevent the domestic violence cases also. And at the same time, I always tell that not only the women to be taken care of, the man also needs to be taken care of. So all the best to all of you, and thank you very much for inviting me. Thank you.
Thank you, madam. Thank you. Thank you for your nice words and a very important initiative, what you said about everything regarding the awareness among the public, as well as about the upcoming preventive aspects of the newer trends, which we have to keep in mind. Thank you so much for sharing your knowledge, ma'am. It is a real great pleasure to have you with us.
Thank you very much. And I need to go because my mother is sick. So
Thank you,
ma'am.
Thank you.
Thank you. All the best.
Dr. Chelani, sir, I have a question. What about the mental health for a preconceptional? Because we've seen those women with the family history or the, they tend to develop postpartum depression and other things. So
Yes,
what is the preventive?
That is very, very important, ma'am. The patient is with us for 9 months, more than that. So we are able to judge that there's some problem with her. Like, first of all, preconceptually, we should see the psychological status of the mother, women, whether she is able to carry the pregnancy. So whether it's safe for her to get pregnant. And suppose she comes late to us during her pregnancy, then we have to be very careful there, because we can't use all that drug very judiciously, because those drugs do hamper with this thing. So that is important. And as you talked about the postnatal depression, that is getting very common these days. So it's very important for us to, after her delivery also, she should be in touch with us, and proper counseling should be done. Family members should also be counseled regarding this, that this is the cause of her problem.
Thank you, sir. Thank you, sir. So,
can I just add one more thing? Raviji, this was so important, Dr. Tatapudi, madam. Periconceptional period, if they are stressed out, there is so much, even in an ART pregnancy, we talk about epigenomics. It's a huge itself, a different, and can cause lot of problems in the developing embryos, and a lot of maybe not only genetic, but also the metabolic diseases in future. So all these matters, that is a Barker's hypothesis, also comes into the picture with epigenetics. So periconceptional stress factor is so important, whether it is a natural conception or assisted reproduction.
Thank you, madam. Thank you. Thank you for your...
Yeah, that was extensive coverage of the vast subject in short time. Congratulations, Dr. Chelani, for your very good talk. And each topic will have its own elaboration, and we have to go into detail, almost a chapter of everything. So even asthma, everything for preeclampsia prevention, everything will be individually, we have to know. So because it's a short time, we have covered every detail, all the topics, including psychosocial aspects and domestic violence, all those things, communicable, non-communicable diseases, even obstetric problems, all those things were well covered. Congratulations and thank you.
Thank you, madam. We have the great pleasure and honor
and
to
now,
have...
one more thing I would like to say now, like, just a moment. Long way government is doing, they have ASHA workers, they go to from place to place, house to house, and now, like Jaydeep madam was there, she's told about the IMUMS app, and it's really wonderful. Even the educated people, the high-tech people who are using more mobiles and all, they can, through those apps, they can be in touch with the doctors, and that can play a very important role, apps like this.
As my co-chair told, awareness in the public, in spite of literacy also, education also, they are not aware of health problems, and there is something like prevention exists. So that awareness has to be created among the public, among the women.
Thank you, madam. Thank you. We have with us Madam Dr. Yashodhara, Vice President, Foxy. Thank you, madam. Thank you for joining us. And we have the great pleasure and honor to have you here, ma'am. On behalf of Oxy, we welcome you, ma'am. Can we have a felicitation from your words, ma'am? Ma'am, unmute yourself, ma'am.
Thank you, Dr. Jairani Kamraj. I am really thankful you have reminded me, because it's really, institute is going very tough these days. So, excellent topics which you all have organized. Very important topics, in fact, preventive care to improve the obstetric outcome, steps to prevent infertility, and facts to improve fertility. I'm really going to listen to it by none other than Dr. Sunita Tendulkar, and preventive steps to prevent cancer in women. There's a very important topics, Dr. Jairani, you have chosen, because prevention is the answer today. We always have said that prevention is better than cure. But only thing which I would like to say to all of you are very learned person. Your Secretary General of the South Society of India, OBGYN Society of India, that's a Kundevi Shankar, and very learned chairpersons, Dr. Satish Dhamakar, Dr. Kamni R. Patel, and Rajal has just left, but I know she's a good friend. Dr. Radha, good questions. I just want to say one thing, that we should talk. When we say prevention, we should talk about the ground level. What is really prevalent? Not all the factors which you are going to enumerate. Like gonorrhea. I just want to ask, how many of you have seen the cases of gonorrhea? Hardly any. If you ask somebody how to collect this smear for gonorrhea, probably you will not get a correct answer. So I just want to say that when we are talking to the population, to the awareness, we should talk about what is really prevalent at the ground level. Mental health, really, it is much, much needed. You have also said it is a preconceptional. Sunita was talking about the preconceptional. Because we say in recurrent pregnancy loss, it is a tender loving care. So that means you are de-stressing the woman. So that's most important. Pregnancy is a real magic, probably from the God's creation. You do not know where you are going to go wrong and where you are going to be correct. Sometimes you think that why this has happened to this woman. So it's a very, very important topic, good topics. And I am really thankful to you, Dr. Jairani, that you were reminded me twice, but only just because of my institute and my meetings, I could not connect at the beginning of it. So I really feel sorry about it, but it was very learning things, learned talks. And the two more speakers are there, Dr. Sunita and Dr. Priya Ganesh Kumar. All are very, very learned speakers, I must say, to your talks. So I'm going to listen to you, Dr. Sunita. The facts which can improve fertility is very interesting, I'm sure about it. Because then smoking, why we should forget about the environmental pollution, which is more than any smoking. We talk about 10 cigarettes, 20 cigarettes. But if we are not keeping our glasses of the car, which very few people have got that luxury, so they are smoking more than 50 cigarettes per day probably. And probably this is the cause why the FGR is coming. So how we can stop it, I do not know. I don't have answer to many questions, but I can just say that some basic needs are very important. Environmental pollution has to be taken care of to improve the fetal health and Baker's theory that Sunita was talking about it. So thank you so much for giving me the time, inviting me for this webinar, which is wonderful, very nice. And my blessings to all of you for your future endeavors. Thank you so much.
Thank you, madam. Thank you for the lovely
Namaskar.
words, ma'am. Thank you
Dr.
for the
Jaideep, namaskar.
Thank you, madam. Thank you for your lovely words. Thank you for joining us in midst of your plenty stressful work and your commitments. Thank you for being with us. Thank you so much, ma'am.
You're most
Over to
welcome.
Gundave.
You're most welcome.
Raji, can I have the chairperson CV for the next speaker?
Raji, are you here? Rajeshwari?
Yes, ma'am, I'm just sharing one second.
Thank you.
Yeah. It's my pleasure to invite Dr. Kamini Patel, founder and director of Vani IVF Center, IVF specialist, and senior IVF consultant, SIMS Hospital, president, Ahmedabad Society 2022 and 2023. And she's a part of menstrual hygiene program under Foxy and Ahmedabad Society, and a lot of publications for her credit. And she's a chapters written for school books on adolescent health. Very surprising, like we have all the topmost chairpersons was taking a lot of care on the adolescent health. And because the prevention starts from the younger age. And she's published and won the best paper presentation for a randomized controlled trial of intrauterine perfusion with GCSF. Next slide. The other one. Yeah, my pleasure to introduce Dr. Satish Damankar, consultant OBG for the experience with 28 years, and associate professor, University of Malaysia and Kale International Medical Program, president of Belgaum Society, and participated in national and international conference, observer for Karnataka Medical Council for many CMEs and conferences, special interest in endoscopic surgery and ultrasonography. Over to you both to introduce Dr. Sunita.
Shall I introduce or Dr. Satish wants to introduce?
Should I introduce?
Yeah, you can go ahead. You can go ahead.
It's always a pleasure to introduce a dynamic gynecologist and obstetrician who has a well-being of every woman in her heart. Dr. Sunita Tandulwarkar is, besides being a famous infertility specialist, she is head of the department and chief of IVF and Endoscopy Center, Ruby Hall Clinic, Pune. She has been advisor and consultant to Dr. D.Y. Patil, IVF and Endoscopy Center, Pune. She is a founder and medical director of Solo Clinic IVF, a new concept, a center for excellence in infertility, Pune. And she is a founder and medical director for Solo Stem Cells, a stem cell research and application center, Pune. Her extraordinary achievement has been India's first stem cell baby and world's first at the age of 45 on 16th April 2018. Madam, on her journey as an obstetrician and gynecologist, has won many laurels and awards. And to name few of them, Bharat Gaurav Puraskar.
That's okay, Satish.
Yeah,
She has
authored 8 books and she has 29 plus publications, 60 plus keynote addresses, 37 orations. And we are really blessed to have Dr. Sunita Tandulwarkar to deliver a lecture here. And I thank the organizers for giving me the opportunity to be the chairperson. Madam, the stage is yours.
Thank you. Thank you so much. Jairani, first of all, congratulations. Yeah, beautiful topics out of the way you have selected these. When you told me to say, I was thinking I'm not going to prepare a talk or a slides. I'm just going to talk on that subject because it's an endless subject and it's so difficult to compile in the slides. But then I thought it's okay. Dr. Kamini and Dr. Satish, very dear friends, both of you. Thank you for being here as a chair. Dr. Jaideep Malhotra as a chief guest and Lakshmi Yashodhara as a guest of honor. Wonderful to have you. Namaste and Vanakkam and Namaskaram, Namaskar. Thank you all. Let me go to the topic directly. I do believe that in 15 to 20 minutes we cannot, but I just feel like certain factors we should be talking and we should be knowing about it. Steps to prevent infertility and facts. Can we really achieve this? Can we really prevent infertility? Is infertility on the rise? The thought when she told me to speak on this, these are the two first things which came in my mind. 15% of the reproductive age group couple, that is 60 to 80 millions, are all over facing the infertility. In WHO 2021, they published this. If you see the World Economic Forum 2022, the global decline in the fertility rate, and at every step, there was a decline from 1950 to 2022. So if one has to take the steps to decrease the infertility, you cannot prevent it, but can you decrease it? What are the things I would look into? What is the age of a marriage? What is the duration? Because marriage nowadays is not important, because even after marriage, planning of the pregnancy, they think 10 times before they plan. No one is settled in life. I don't know the definition of settlement for this young couple. Lifestyle factors, of course, there are a lot, female as well as male factor. I think Yashodhara was commenting strongly on environmental factors, and I totally agree with her. Obesity, awareness about how the pregnancy happens. You know what? We don't have to see only the metro cities or those who are educated, who can read on a Google, but there are certain 30 to 40% of the couple also, they're not aware how the pregnancy happens. What is the fertile period? So even if the couple come to your cabin and when you ask, you will find 60-70% educated. They will say, okay, we are aware and we were trying during that. But then 30-40% will also say, what's that? What's the fertile period also? So what is the natural fertility? Most pregnancies, if they plan unprotected sex in a good age group for 6 menstrual cycle, probably they will conceive. The maximum fertility rate of approximately 30% per cycle have been reported in first 2 cycles, and fecundability decreases as the number of consecutive months without achieving the pregnancy increases. So we all know that at the end of 12 months, around 85% will conceive on its own. Now, how does the age affect the fertility? Women in their late 30s are approximately 40% less fertile. When I read this figure, it really brought a goosebump, because no one is planning the pregnancy at early 20s. Everyone is planning in their late 30s, and they have natural decline by 40%. The probability of conception is highly dependent on the age, but paternal age also plays a minor role, especially after the age of 50. Now, lifestyle for the male and the female partner, most important is use of a tobacco by the female partner and possibly by the male partners is associated with subfertility. I don't know, but in my part of the society, I see so much of this hookah and the tobacco. It's all going on. It's not only just the smoking and alcohol. There are the hookah centers and there are these tobacco centers. So more serious report that fecundability is decreased if the female partner smokes more than 10 cigarettes per day. Observational studies suggest that much of the subfertility is associated with smoking can be reversed within a year. So if the lady comes to your cabin, oh my God, for last 10 years, I'm smoking 10 cigarettes. It's okay, accept. But now you change, revert. And maybe you can counsel her if you really, though I know it is very difficult to stop suddenly, but if they stop it, they should understand that probably they can revert. The dose-dependent decrease in a semen quality have been observed in a woman, in a man who smoke, but available evidence does not prove. I tried to get as many publication as possible, but there was no evidence to prove that smoking decreases the female fertility. I have gone through several publications. Means, Jairani, you made me read a lot. Possible mechanism for subfertility in smokers include adverse tubal or cervical changes, damage to the gametes, and increase in the spontaneous abortion or ectopic pregnancies. Numerous studies link the smoking to early menopause, that cigarette smoking can cause premature depletion of ovarian pool of oocytes and premature aging. And I feel similarly, we should think about in a male partner as well. It will affect the gametes and the quality and quantity. Components of cigarette smoke may cause oxidative stress and DNA damage to the ovarian follicle. Now, if it is causing damage to the DNA of the oocyte, obviously it should cause a DNA damage to the male partner. And I felt that this is the next study I'm going to give to my fellow, effect of smoking on the semen parameters. I never thought of doing that. Moderate alcohol consumption, less than 2 drinks per day, probably has no or minimal adverse effect on fertility, but higher level of alcohol consumption should probably be avoided when one is attempting the pregnancy. Abstinence from alcohol at conception and during pregnancy is generally recommended because a safe level of prenatal alcohol consumption has not been established. How much one can think of. Even the pregnant lady, if she comes and says me that if I'm taking one peg in the evening, is there a harm? I can take a wine. It's better we say that you avoid it, because we don't know how much quantity itself is a good. There are no studies which has proven it. Heavy alcohol use by the male partner is related to the abnormalities of gonadal function, including reduced testosterone production, impotence, and decreased spermatogenesis. And definitely this heavy alcohol should be stopped. These are in 2020, very interesting article, cross-sectional study of association of alcohol intake and the semen parameters. This study was beautiful, and they found not only that affect the sperm parameters, but the testicular volume also, they have found that it was decreased. Now, environmental factors, environmental pollutants, as Yashodhara was saying, if you keep a glass window down, you don't know how much environmental pollution. We all are facing decrease globally, the decreased ovarian reserve. And I tell patient, I don't know the reason, if it is not genetic, but maybe the environmental factors, the chemical on a food which we are eating, the electromagnetic waves from the all electronic gadgets, apart from just the stress and the lifestyle. So environmental factors definitely will have a lot of adverse effect in fertility as well as pregnancy. Sonabathing doesn't. You know what? Patient definitely ask, I go for a habit. I have a habit. I take a sonabath regularly. So for that time, I had read, because obviously when you take a sonabath, you start thinking it's a hot atmosphere, and that may affect the sperm parameter if longer and more frequent sonabath. But there is no evidence as such. They say that it will cause, and it is a transient change. Now, overweight and obesity. I'm going to tell you something different. Again, thanks to Jairani. Both overweight and obese BMI have been associated with decreased fertility. Yes, obesity as well as undernutrition, we all know that. But the effect of BMI on male infertility is unclear. A BMI of 18 to 25 is associated with good reproductive outcome. Most studies have shown that BMI greater than 27 or BMI less than is associated with ovulatory dysfunction, and that's why infertility. But even in regularly ovulating women, increasing obesity appears to be associated with a decreasing spontaneous pregnancy rate and increased time to pregnancy. And probably maybe the hyperinsulinemia, which is a common factor with the obesity. One can think about causing anovulation with this parameter. But Prior observational studies have reported that both non-surgical and surgical weight loss increases your frequency of ovulation, increases your chances of natural conception. However, weight reduction does not appear to be associated with increased fecundability or the live birth rate. And that was very, very important for me to bring to it. So it may cause increase in a ovulation rate, natural conception, but whether it is causing live birth rate, we don't know. And 2022, this is a recent study of a FIT, which is called FIT, please randomized control trial. What this was is a preconceptional lifestyle intervention for weight loss. It did not improve the fertility or birth outcome compared to an exercise intervention without targeted weight loss. So improvement in metabolic health may not translate into the improved female fecundity. And I was surprised. Every patient, especially the PCOS, of course, I tell them, you go, if they are not planning pregnancy, I like it. She comes to me only for a menstrual irregularity. I get a chance to sit with her and explain her, just don't use contraception. Go for the weight loss, your menses will become regular and probably you will conceive and you may not need us. But certain publication and all, I thought this is very important to know that we may not give a false promises to the patient. This is another 22 study which has come last year. Impact of BMI on the success rate of fresh embryo transfer in women undergoing first IVF fixing. So again, if it is the BMI, and again this study says that BMI was not associated with embryo transfer outcome, whether it is a positive rate, clinical pregnancy rate, implantation rate, ectopic pregnancy, ongoing pregnancy, miscarriage, and live birth, all after the fresh embryo transfer, whereas BMI was associated with GDM and gestational hypertension. So overweight is probably may not, by decreasing the weight, we may not achieve increased fecundability, increasing live birth rate. Now, obesity and male partner, as I said, the impact of male partner's BMI is not even examined extensively, and some observational and animal data suggest there may be association between this. Again, it opened my mind that these are the topics which are simple observational studies we should be conducting. There are so many fellows in the department, and these are so simple studies. We can think about doing a multicentric studies also with this, because no much data is needed. It is very easily, even the junior fellow can help you to compile this. What Dr. P.C. Mahapatra says, those who work don't publish and those who publish don't work. Probably the time is changing, and it's important that we publish of people even after when we are no more in the world. So I believe now tremendously in publishing. There is a consistent evidence that the obesity affect reproductive hormone level, but studies have reported conflicting results in obesity on semen parameters. This is very important study. I think we, in the city of Pune, we talk about the waist circumference, thanks to Dr. Shirish Patwardhan, who keep on talking waist circumference, BMI, and he always believed that it is going to give us lifestyle diseases in future. What is this study data from the life study says that ejaculate volume and the sperm count showed a linear decline in increasing BMI and waist circumference. So instead of just thinking about BMI, can we think about only waist circumference? Because they did mention that there was no significant relationship between the body size and semen. So let's thinking more about the waist circumference. Obesity and risk of abortion? Yes, that probably may be the another. Now, 21st century epidemic of obesity, is it an impact on a pregnancy loss? There is a clear negative effect of obesity on the quality of the woman oocyte, embryos, hormones with a high body mass. So we should say the first trimester as well as third trimester complication, maybe more. Healthy lifestyle, caffeine. Now the lady asked, I'm drinking coffee. How much I'm supposed to allow? take it. Sometimes, you know what, those who are taking coffees or a caffeine and those who are addicted, without it, they get headache and all. And suddenly if the husband start eating their head, with the couple come and talk to you that does her excessive caffeine is helping. So female fertility does not appear to be affected by caffeine intake less than 200 milligram per day for a woman undergoing IVF therapy, but there is no strong evidence to support limiting caffeine intake in the male partner. Preconception caffeine metabolites or caffeinated beverage intake and fecundability. They say that baseline intake of total more than 3 compared with 0 serving was not found to influence the fecundability, nor was the caffeinated coffee or the caffeinated soda of more than 2 servings per day. So exercise. Female fertility can be adversely affected by the increase intensity and duration of exercise. This is very important for all of us to understand. If they do vigorous exercise, too heavy, so especially the obese patient, when you are telling them to do 2 hours cardiac in the gym and then so much of a 10,000 steps a day walk and all, one has to listen to my further slide where they have said that if you do very vigorous exercises, it may affect your fertility than helping you. For this reason, it is suggested that one with the BMI less than 25 who are attempting to conceive should limit the vigorous exercise to fewer than 5 hours per week. Don't keep on just doing so much. The specific type of exercise does not appear to be a factor. The effect of strenuous exercise, can be whether there is a reduced progesterone production during the luteal phase. Does it cause luteal phase defect? Does it cause GnRH production alteration? Whether it affects the pulses, whether the LH-FSH secretion goes down, and that's why the estradiol production or the HPO axis getting affected, not housing the healthy oocyte, whether it is causing changes in the leptin level. One has to think and one has to work on it. Effect of physical activity. This is a beautiful meta-analysis published in 2022. I thought of taking all publications of 2022 because it's very important. We should know what the recent things. For years together, we are saying the patient, keep on doing this, keep on doing that. What does it do? The effect of physical activity and sleep duration. They said that high intensity physical activity negatively correlated with the fertility. However, no association is found between the moderate intensity and fertility. So you should be explaining the patient, don't become cranky. The husband wants her to join 2 hours of gym and then 10,000 steps and then 1 hour of yoga. Her mother-in-law forces her to do all that. It may be causing a stress also apart from this. But very important is she should get a sound sleep. Inverse association between limited sleep duration, less than 7 hours, and fertility compared to 8 hours sleep duration. So it's important that she get a peaceful sleep. Male fertility does not appear to be affected by the exercise. In men, overall, none of the men parameters, they found they are affected by the exercise. However, those men who use the bicycle for more than 5 hours per week demonstrate lower sperm concentration and lower number of total motile sperm, probably increasing the local temperature. The stress factor. We all speak about environmental stress, ecological stress, emotional stress, physical stress. All these can affect the HPO axis and it will affect your FSH-LH ratio. At the same time, it will affect your central nervous system, HPO axis directly getting affected. So the stress, whether it is environmental, ecological, emotional, physical, all is going to affect. And exogenous glucocorticoid exposure because of the stress factors on the fetus is going to affect the adulthood diseases. I think we all hear so much. I heard first time from Jaideep Malhotra way back, the adulthood, origin of adulthood diseases in the womb. And I just loved that talk. And then I made my own talk on that. So I think it's very important. We talk about 1,000 days of a fetus, first 1,000 days in a life of a fetus. That also 9 months goes into the maternal womb, and any stress increasing the steroid can going to affect and giving adulthood diseases to that baby. Lifestyle and fertility, the influence of stress and quality of life again and again, though it is, we have to understand and make them explain about all the stress factors. Cellular phone and radiation. This is very important. Does it affect? I definitely feel it affects. Why there is so much of an increase, decrease in the increase incidence of decreasing ovarian reserve, premature ovarian failure. Those who are ART consultant, they must be at the end of a day getting shocked that in a day, they must be seeing less than 1 AMH in at least 30-40% of their total OPD. Though the incidence we say 10 to 15% of the decrease globally, but if you see the ART OPD, those OPD definitely see the incidence very high. And I feel definitely the young generation with the cellular phone, I think more and more 24/7, the kids also love to play on that. They have 2 hours per day to play on the cellular or on the iPads, and it's going to affect. No one has studied for the female partner, but for the male partner, yes, they have studied about it, and they found that there is a damaging radiation to the male reproductive organs, increased levels of DNA fragmentation. And IT industry, I always tell, it's not only the electromagnetic waves coming from your laptop, but sitting on a laptop for a long in a chair itself may increase your testicular temperature. And that's why they should do the round 1 hour, 2 hour. Some may have a habit of keeping the laptops on their lap. So there comes the protective shields. They should be using it or keep the laptop on the table. Very important. All we have to talk. Apart from just having these gadgets receiving your radio frequency electromagnetic waves, that definitely affect the motility, number, and morphology. Higher serum free testosterone and lower LH level were reported in those people. And there is this systemic meta-analysis published in 2021, mobile phone users and high mobile phone was found to be, but there was no definite, this is very important, there is no definite cutoff time, how many hours you can use, whether you can use 2 hours a day, and that should be enough. As long as they know that it is not only the fertility, you don't know tomorrow whether it is affecting your heart, whether it is affecting your GI system, whether it is affecting your neurological system, your brain, because you are thinking totally different. It may be affecting your eyesight because you are exposed to so much of a brightness whole day. So we don't know the consequences. So those who are fertile, those who have kids, they also should be aware of all that. Anxiety, depression, yes, they do inhibit the our HPO axis, and it is going to affect the glucocorticoid. They will affect the LH hormones, the ovarian estrogens, and the progesterone secretion, and they may cause amenorrhea as well. We all face a lot of 10th standard and 12th standard students coming with their mother that for 4 months they did not got the menses, the only because the anxiety and stress affecting the HPO axis. It is recommended that infertile couple, despite desiring the conception, are encouraged to avoid the anxiety, depression management, and that's why the role of counselor is very important in any fertility clinic. So to conclude, friends, most lifestyle factors are theoretic. Frankly speaking, I cannot conclude on every subject. We can speak for 2 hours on one slide, but to summarize, most lifestyle factors are theoretically modifiable habits, can be reversed with the strong determination by the affected subject. Public enlightenment by the healthcare providers will go along to increase the knowledge and improve the awareness of the population, since most are not aware of potential consequences of a lifestyle habits on infertility. Counseling of infertile couples may enhance awareness of the risk of lifestyle behaviors and facilitate the appropriate lifestyle changes, which may improve their reproductive health. Friends, before I leave this stage, let me appeal you that I'm going for a Foxy presidential election. It is going to happen in September 2023. I humbly request to bless me. I know this is an educational platform, but I got a chance to communicate with you. So I thought of sharing that news to you. Thank you so much for an opportunity once more. Thank you, Jenny.
Thank you, Dr. Sarita. It was a wonderful deliberation, and this topic is so close to my heart. And as you say, that all the couples, I don't know what time is the right time for this couple to head with for the family. Everybody wants the perfect time. No, this is not the time. I don't know what they are waiting for. Even after 5 years of their marriage, no, doctor, this is not the right time. So what we have started is we have started counseling them for oocyte freezing. Okay, do one thing. At least do the oocyte freezing by 32 or 35. At least do this much. We are praying them.
I feel 35 is late. You know what, Kamini? I used to advise, wait, when they come to 32, 33, I used to advise a decade ago, maybe wait, you may get married and you may not need. But 35 was my age that time. Now 35, I may not get enough oocytes. So even at the age of 28, 30, she says, I'm not going to plan even the marriage. I say, freeze out. Younger the age, I need to do lesser cycle or maybe one cycle, and I can freeze out 15 to 20 eggs because there's no point in freezing 4-5 eggs of them.
Correct. So true. So anyway, we have started counseling the girls in the colleges these days. So first counseling is early marriage, a good lifestyle. Get your marriages early, but here the marriage is not reproduction. The marriage is only the marriage and finding a partner and a comfort zone, And then after that comfort zone is over, we may think about having child and they don't want to disturb their comfort zone. So I said you better start freezing your eggs, because one fine day you want to have your family and then there are no eggs. Sperms, I mean, you may have the male partner giving sperms very often, but what about the eggs? Where will you get the eggs from? So we have started counseling right in the colleges, and everybody everywhere should be doing this. That before the girls
but you know what I feel, Kamini, it's not only the egg freezing. By the time they're planning, they may got fibroids, they may have adenomyosis, which also will affect your implantation results. So we should be telling them that even if you have frozen eggs or embryos, try to understand that you may have some uterine factors which otherwise would not have been in your way, causing problem in your fertility.
When he is speaking in the colleges, they feel like this old lady is just, some blabbering going on, and they do whatever they want.
I agree.
Sunita ma'am, I just want to have a little different opinion. See, if the patient comes and asks you, so how far is my safety of this oocyte preservation? What is the long-term effects? What is the effect that you're going to give an assurance of? Because nowadays we see a lot of vitrification embryos, they have an increased risk of cancer. There are a lot of reported childhood cancers are increasing. This is among our faculty. We should also have
You know what, Jairani? I totally understand. So we should not be giving false promises.
Correct.
But you know what? No, Italian people, the government, I don't know now, a decade ago when I had sat and discussed with Ubaldi and all our Italian friends, the government never allowed them to fertilize more than 5 or 3. I don't recollect down the figure.
Yeah, that's what. Ubaldi was telling Vatican, they don't do it, ma'am. That is what.
So if they are freezing over the ages for last 40 years, I feel if they are saying it is safe in the Italian people, I will like to believe that much. But I totally understand and agree with you. The long-term consequences of the these kids which are coming, also we are not aware. Forget about just giving the pregnancy, but epigenomics. That is what nowadays the studies have come when a blastocyst transfer, when from day 3 to day 5 you go, you have so much of a cytoplasmic changes happening and epigenomics changes, and we may be giving a trouble. So whether we should go back to day 3 transfer, all these are very, very important. Same, I feel, those who are doing rampantly ovarian PRPs, I feel they don't even think. I think, what, if the PRP is going to stimulate the intraovarian stem cells, it may stimulate intraovarian tumorogenic cells. Whether these women will have 10 years down the line malignancy ovarian, we don't know. We don't know.
That's what. Before the Second World War era, there was no environmental pollutants, anything, nothing was there. After the petrochemicals,
we go back to the Indian culture.
Now we want to go to the villages. We want to go to the nature now. So it is something the technology comes and we have a bad. We have to think of the long-term consequence of all the technology, how it's going to affect the nature. That is what every nature has its own.
We are trying to overcome the nature. I agree with you totally.
That is what we have to always think of nature. That's what we have to educate them. Instead of educating them.
Jairani, our Indian culture, marriage in early 20s and having the first kid between 23 to 27 age group was the best thing anyone can have. And they enjoy their grandchildren and everything. I don't know what is going to happen with us.
We should tell them, when we start the counseling, we should tell them the goodness of these things. And then only we should think of talk with the adolescents about this oocyte freezing and all. That is always.
Agree. Totally agree.
After that, we just leave one chance for them that if you don't follow this, you have something on you. Otherwise, we don't want them to take up a donor oocyte, isn't it, later on?
Yeah.
So, all the goodness that, okay, you're going to take up the transfer. You're going to conceive, have an early pregnancy. You're going to save your uterus. You're going to save your fertility and so many other things, But in spite of listening to all these things, they are so adamant, girls these days. I fail to, explain them further.
Thank you, Sunita. That was very fantastic of bringing out everything.
You made me read a lot.
Simple way, yeah.
You made me read a lot.
Madam, thank you very much, because you brought out that infertility is not just a anatomical endocrinological disease, but it is also a social problem which we have to address on a priority basis. Yes. Because the very belief of the youngsters in the institution of marriage is only crumbling. So we need to first reinforce that marriage is necessary, and subsequently we should say that earlier you get married, earlier you have kids, everything will be fine, everything will be physiological. But the problem is their obstetric career and their academic and career is at crossroads between 20 and 30. It is a very big challenge to address that, because both their careers are simultaneously running and their age is taking over, and their career prospects are also at stake. So it is very difficult, but madam, you have made it so simple and so meaning everybody can follow your advice, and let us hope for the best for the next generation. Thank you very much.
Thank you, Dr. Satish. Thank you so much, Dr. Satish. Thank you.
So thank you, ma'am, for the lovely talk. We move on to the next session. Can we have the CVs, Dr. Raji? Dr. Premlata, Madam CVN. Yeah, it's my pleasure and honor to introduce Dr. Premlata, ma'am. She's a consultant head of the department, Dr. Mehta's Multi-Specialty Hospital, Chetpet, Chennai, retired director and Institute of Obstetric and Gynecology, and past president of Oxy 2022. She made every one of us to be very homely during her presidentship. An executive member, Chennai Menopausal Society, and member of ISOPAB, and vast experience and published articles, expertise in tubal microsurgery, and authored a lot of books. and recipient of Lifetime Achievement Award by Emcure University 2012. Next slide. Dr. Manju Singh. Raji.
I think the others,
yes, ma'am. Probably others.
Other chairperson was brought for the previous session.
Dr. Manju Singh was one of the chairperson, but I'm not able to see her. Maybe you can start introducing Dr. Priya Ganesh, ma'am. Can we have Dr. Priya Ganesh's CV?
Thank you, Dr. Jayarani and Dr. Kundavi for giving this opportunity. It's really a very wonderful webinar on preventive care. Actually, preventive obstetrics, preventive infertility, all had been very much detailedly, it has been dealt with, and it was very interesting. Now we go on to the very important topic of preventive care, preventive steps to prevent cancer in women. As we all know, WHO has given a guideline of 90, 70, 90 to eliminate cancer cervix. And to give a lecture today is none other person than Dr. Priya Ganesh Kumar, who is the chairperson of the Gynecological Oncology Committee, FOXY 21 to 25, to deliver this lecture. Going through her CV, I'm really very astonished. She has been done wonderful service on preventive oncology. She has been a WHO, IARC, IFSCRP, colposcopy and cytology course trainer. She has trained more than 1,000 gynecologists pan-India in colposcopy course. She is a medical director of Shinivas Healthcare, which is a chain of preventive oncology centers pan-India. She has been having a lot of award mainly for preventive oncology. Thane Gaurav Mayor Award for Preventive Oncology, National Award for Zeke Induzon Spestia Award for exemplary work in the field of preventive oncology, Economic Times Inspiring Doctors Award 2018 Delhi, IMA Excellence Award, Wonder Foxian Award 2019, and she has had a Golden Awards Most Dynamic Gynec Oncologist of the Year 2022. So she has published books on colposcopy in practical gynecology, author of Atlas of Colposcopy and Cytological Changes. So she's a very apt person to deliver the lecture on preventive care in cancer in women. Over to Dr. Priya Ganesh Kumar.
Thank you, Dr. Premlata. And thank you, OG Society and Dr. Jayarani and everyone. I've been hearing right from the beginning, and I was really intrigued by understanding so many preventive, care in infertility, in pregnancy, and of course now in malignancy. And I hope after so much of an in-depth dwelling, people aren't bored and don't want to listen to malignancy, because malignancy always have been at the backhand of the people's mind. But believe me, dear friends, preventive oncology is now taking up in a more specific manner, in a proper formulated manner, and it is itself a branch on its own. It is not a sub-branch. So that's one thing for us to understand. And I bring greetings from my committee and from my institute from Mumbai. Now, talking about cancer, we have different aspects of cancer. One is preventive part, one is screening and early detection. Once you detect it, it's a cancer treatment. And then last is palliative care, even that's picking up. So that's a comprehensive cancer care. But when we are talking about prevention, we do have two main aspects, screening as well as vaccination and all that. Now, today, I'm not only going to dwell on cervix because it's going to be malignancy on a whole. So I'm going to talk on breast, on ovary and endometrium and cervix. So let's understand in a more compact manner. A lady comes to us and we do not want her to go into any of these cancers. That's exactly what we have to understand. And also when we are holding this Well Women Clinic, this becomes a very important topic when a lady walks into your center. Now, one woman dies of cervical cancer every 8 minutes. Then if that is so, then breast cancer, every 2 women. I mean, they are detected and they are diagnosed every minute. So now talking about tobacco, we had enough of tobacco discussions for the past two talks. And we have been seeing that these tobacco users are increasing daily. I mean, now 3,500, this is the estimate, persons every day. And the tobacco users, men, women, everywhere. So understanding this fact has become now a very important topic because oral cancers are on rise, even for females. And you would see over here that the main 5 cancers for men and main cancers for women. Now, for women, it is breast, again, lip, oral, cervix, lungs, and gastric. Now, what Dr. Sunita Tendulkar was just mentioning, I'm reiterating that fact. Hookah clinics have increased, hookah joints, and all these things have really become like a fashion nowadays. And if you do not have it, you are not into the society, something of that sort. So that's becoming a fashion, and that's why you are seeing oral cancers increase. Now for breast cancer, now I'm going to take up the breast. Now you will see that the new cases in Globacon 2018 was 1,62,000 was the incidences, which rose to 1,78,000 in Globacon 2020, with the deaths of 87,000 rising to 90,000. And you see that 1 in 28 women, can develop breast cancer during her lifetime. And if you see, rural compared to urban, you will see 1 in 22 developing breast cancer that is in the urban population, to 1 in 60 developing that in her rural areas. Now, this is the Globacon 2020, and I had just told you that breast cancers are contributing to 26.3% of all the cancers, and the number 1 leading cause for death due to cancers. What are the risk factors? There are hormonal and there are non-hormonal. Hormonal, because of increased exposure to estrogen, you can see that early menarche, nulliparity, late menopause. Then non-hormonal causes like radiations, if she has taken for Hodgkin's lymphoma, that increases the probability of 75 times. Now, there are various risk assessment models which are available. Like, there is one called as Gale et al., who has incorporated age at menarche, then age at first live birth, number of breast biopsy specimens, any history of atypical hyperplasia, or any familial history, first degree relative. That gives the risk score. Then another one is Kloss et al. Now, what is that Kloss et al.? How is it different from Gale et al.? Let's understand. Now, here he sees this Kloss et al. Sees the prevalence of high penetrance breast cancer susceptibility genes. And compared with the Gale model, it is more information about the family history. But then other risk factors are excluded. Then comes is BRCA-PRO model in Mendelian model. Now here what they see is, they see for the carrier of mutations in one of the breast cancer susceptibility genes. Then when we talk about the screening, now one thing is, whenever there is a low risk, normally we don't screen, age under 40, we do not normally screen for an average risk women. But then 40 to 49 is a cusp. Should you or should you not? Various guidelines are showing about 50. But in India, we usually say that you discuss with it, you recommend screening, and you can, if they are ready to take it up, screen with mammography every 2 years. But 50 to 74, yes, definitely you will have to screen her with mammography every 2 years, and above 75, actually there is not much of a need if she would have done all these things properly. Now, benefits and harm. Now, what are the benefits? Now, the meta-analysis study had shown that, it was a 2012 meta-analysis that included multiple randomized trials. And this involved 6,000 women from several countries. Screening mammography was estimated to reduce the odds of dying of breast cancer by 20%. But what is the harm? Harm is overdiagnosis, false positive findings, patient anxiety, unnecessary treatment, associated risk. Now, what is overdiagnosis? Now, overdiagnosis is, these are the cases which will not have any clinical consequences in women's lifetime, So it has been seen that overdiagnosis occurs from the range of 10 to 50%. And most of the times, these lesions confined to mammary ducts, which are called as DCIS, they're biologically insignificant and never have become clinically evident, overt cancers in patients' lifetime. So these are the over-diagnosis thing. And another thing is false positive mammography. Like if you have a dense breast and all, younger age group. So these increased breast density, these things, or younger age, or the current estrogen usage, all these things can have false positive mammography. Again, radiations danger is there, but then of course the radiations are low enough that then you are comparing to CT and all that, and discomfort is definitely there. So there are various modalities. You have mammography, sonomammography, ultrasound, ductography, MRI, and gene mutation studies. Now, breast cancer screening, the breast, below 50 years of age is more controversial. Why? Because the breast is dense. Another thing is false positive test findings. And there is a less probability and incidences of younger women getting into a cancer. Talking about BRCA mutation, now 5% of the breast cancers are caused by inheritance of germline mutations such as BRCA1 and 2. And they are usually autosomal dominant fashion. BRCA1 is located on chromosome arm 17q, and both BRCA1 and BRCA2, they are actually tumor suppressor genes, and if there are certain laws of both the alleles is required for initiation of cancer, that these are the mutation factors. And what is the BRCA1? The isolation of BRCA1 genes suggests a role in transcription, cell cycle control, DNA damage repair pathway. And with over 500 sequence variations, they have been identified. So if there is a germline mutation in BRCA1 predisposing genetic factors, 45% of hereditary breast cancers and at least 80% of hereditary ovarian cancers are being seen with invasive ductal cancers, which are poorly differentiated. Then these are also hormone receptor negative and triple receptor negative ones, ER/PR negative, HER2 negative, or basal phenotype. Now what happens is, what is the distinguishing clinical features? Early age of onset is there, then bilateral breast cancer prevalence and associated cancers with ovarian cancers. And the common mutations you can see is 185 deletion AG and 5382 insertion C. So they are the main cause. Now, what is BRCA2? BRCA2 is seen in the chromosome arm 13q. And this plays a role in DNA damage response pathway. And what are the distinguishing clinical features? They are early age of onset, bilateral breast cancers, and they can be associated with ovarian, colon, prostate, pancreatic, and various other cancers. Now, what is the risk factor? If there is a BRCA2 mutation, is close to 85%, and lifetime ovarian cancer risk close to 20%. How do you identify BRCA mutation carriers? Who are the things, who are the people to be, or the 4-step process? Now you obtain a complete multi-generational family history. Then assess the appropriateness of genetic testing. There are various genetic testing. So normally next generation sequencing or sequential full testing is being done. Then you have this counseling the patient and interpreting the result of testing has to be also told properly. The 50% of the women with BRCA mutation have inherited mutation from their fathers. So that's also very, very important to know. Manchester scoring system is there, Bodicea system is there to understand. These are the tools used in genetic clinics. And the hereditary risk factor, if this is from the Jewish heritage, first degree relative with breast cancer before age of 50, a history of ovarian cancer at any age, or first or second degree relative with ovarian cancer, breast and ovarian in the same individual, then these are the thing. Now, appropriate counseling is very, very important. You do the whole gene sequence analysis can be done, but the first and the foremost thing is, target the patient is there. You first see her gene sequencing, do the complete thing, and then for both BRCA1, BRCA2, and when it is found, then you can do it for the relatives further down. Now, women who carries a deleterious mutation has a breast cancer risk of up to 85% and increased risk of ovarian cancer. Now, what does a negative test results imply? A negative test result is actually, women where the tests are negative. Now, if the mutation is not present in any women, what is the risk factor of breast or ovarian cancer? It is not no greater than the general population. In addition, no BRCA mutation, if it is there, then the woman doesn't pass to her children as such also. So these are the Gale model which has been used, and then BRCA mutation carriers. What should you do? in a case if a patient has a BRCA mutation. Present screening recommendation for BRCA mutation carriers who do not undergo risk-reducing mastectomy includes clinical breast examination every 6 months, mammography every 12 months, beginning from the age of 25 years. Now, the current recommendation from American Cancer Society are annual MRI in women with a 20 to 25% or greater lifetime risk of developing breast cancer. Now, we also have, the risk of ovarian cancer also in BRCA1 and BRCA2. Hence, now these are relating to 20 to 40%, which is 10 times higher than the general population. What do you do in that case? So risk-reducing salpingo-oophorectomy is one of the major stay for a mutation carrier patients. In women with a documented BRCA1 and BRCA2, consider bilateral risk-reducing salpingo-oophorectomy between the age of 35 to 40 after she has finished her childbearing and completed a family. Removing the ovaries reduces the risk of ovarian and breast cancer. Now, this is the Cancer Genetics Studies Consortium recommends yearly transvaginal ultrasound timed to avoid ovulation and annual measurement of serum cancer antigen, that is CA125 levels, beginning at the age of 25. This has to be adopted. There are other various genetic mutations like PALB2, then PALB-B2 is now these things are picking up, Peton mutations, Li-Fraumeni syndromes, then P53 mutations, and these are having various other like Cowden diseases. Now they have, thyroid involvement, GI involvement, or skin or subcutaneous involvements. So genetic risk assessment is very, very important. Take a proper family history and, do this risk reducing surgeries, which are really helpful. And this was also called as Angelina Jolie effect. Now, what are the other breast warning symptoms? Lump, discharge, abnormal shape, contour, pulling of the skin, small mass on mammography. You have to teach the patient self-breast examination, looking in the mirror, feeling it, and raising her arms and finding for any lump or thickened skin or shrinkage or skin color changes, and whether there is any dimpling or whether there are any changes in the nipple or whether there is any discharge from the nipple. These are very, very important. And then is the feeling method. There are two methods. You can go round or you can go in a sequential parallel fashion. And also never forget the armpit. So this is something which you will have to teach the patient. And then these are the mammography. When will you do this mammography and all that? Now, and we know that October is celebrated as Breast Cancer Awareness Month. Talking about cervical cancer, 1 out of 4 women who die of cervical cancer is an Indian. And again, it is alarming to note that, see, now ASR is reduced. Overall, cervical cancer is coming down, but because of the population, we see the raise in the numbers. And also, 8 women die every hour and 1 woman every 7 minutes. So many a times we have these type of services coming to us and we are just giving them, very sorry to say that not many people are really taking up HPV or Pap test, whereas we have to, even a per speculum examination is very important. Nowadays it is TV era and, people just put the probe or paper, this thing, sonography era. So it's always very important that you assess the cervix. And whenever there is any, nowadays the protocols have changed as per that ASCP, this risk symptoms are very important, given a lot of importance for colposcopy. Initially, it used to be only screen positives goes for colposcopy, like, HPV positive or PAP above ascus. But now it is said that even though your screen is negative, yet you find a cervix which is unhealthy, you can still put her up for colposcopic evaluation. Or risk factors like postmenopausal bleeding or postcoital bleeding are very, important risk as a stratification symptoms. You have the risk factors over here. Smoking, we have been talking a lot about smoking and tobacco, and you can see early onset of marriage, multiple sexual partners, high-risk sexual partners, STDs. It is very surprising to know that Mycoplasma hominis, there's a lot of studies which has concomitant STIs, raising the risk of cancers for the cervix along with HPV, concomitant STI infections. So we do have NAT test where we can really, understand ureaplasma urolyticum or mycoplasma hominis, and try to, and then you have got chlamydia, gonorrhea. Dr. Yashodhara madam was talking about how to collect. Nowadays, this NAT test has really become very comfortable, to understand chlamydia, gonorrhea, and all those things. So definitely an HPV infection is the mainstay when you talk about cervical cancer. Now, risk has been there. As site, we know gross lesions can be occult, proliferative, ulcerative, and histopathology types are squamous cell and adenocarcinoma. And HPV persistence is the main cause for it. So the natural progression is whenever there is an HPV related changes from ascus to LCIL to HICIL, and it takes long time. So that's the major beauty of cervical cancer prevention, and really taking it up very seriously. We can one day say what WHO slogan is of 90-60-90, and we can eliminate cervical cancers. And HPV is not only related to cervical cancer, also to various other factors as well. So giving a vaccination invariably is going to give a protection to all these other cancers as well. So screening and diagnosis and educating the patient is very, very important. We see there are a lot of barriers. Like this 4th of this month, there was this World Cancer Day. We did a huge camp at Dindigul with Dr. Revati Jankiram and Dr. Amla from Dindigul Society. And I was invited there from my committee. What we saw was, there were 1,000 more women who had registered. Out of this registered candidates, 867 women actually came for, various other screenings as well. And out of that, only 350 came for, lying on the couch for VIA testing. So can you see the barriers for women? And the barriers are too much. They really do not want to expose themselves and get some instrument inside their vagina. That's something really awful for them. And that's exactly where we have to have our own understanding in place and how to counsel them and what to do whenever there are screen positives, whom to send, how to send, and all that. And the best part of it is WHO's slogan of 90-70-90. We do have this vaccinations, primary prevention, secondary prevention by screening, tertiary prevention by early detection and treatment, and palliative care. Vaccination, we had Gardasil. We have Gardasil. Cervarix is not available right off now, but they are saying that the next product is coming up. So this is bivalent and quadrivalent, and you have nonavalent now. And vaccines are now freely available. And and nowadays, NGOs like Cancer Foundation of India and all have really taken up a lot of efforts in getting vaccination drive. After this Serum Institute's vaccine server are coming up, I think now it's the time they have chosen 6 states. Government of India has chosen 6 states, and Tamil Nadu is one of them, where they are going to get this government vaccine drive, and that as a piloting, and then that will be seen. So we are seeing definite changes, and I am very sure there is a big ray of hope. If we are able to really put in our efforts together, we can see the cervical cancer getting eliminated in our time era itself. So these vaccines are licensed and you can give it till 45, but 9 to 14 is the main prime target thing. And then from 15 to 25 catch-up vaccination, and later you can give it till 45, but tell them that your, the protection will be only 80% as per all those trials which have gone ahead. So now we do have the comparison. And one thing is that people have been asking me so much that I think most of us are getting this questions from the patients. Nonavalent has been introduced, 9 strains. My daughter has been, vaccinated with Gardasil. Can I give her Nonavalent? Is it going to have any additional benefits? We have to understand one thing, dear friends, that the phylogenetic tree of 16 is similar to 31 and 33, and that of 18 is to 45. So whenever you have givens per 16 and 18, you have also covered various other strains, and the only few strains which are not covered, they do not have so much potency to go into a cancer. So there is no need to rush to get her nonavalent vaccine once if it is quadrivalent done. Now, another wonderful sage recommendation came up by WHO, and it has given certain flexibility over timing of the second dose from the first. So they say you can recommend it till 12 to 15 months, sorry. Ideally, it is like 6 months is what we say, right? From the second dose, for the second dose. Now they're saying, suppose if the lady has forgotten that second dose, the girl, you can give it by 12 months to 15 months, and more so you can also increase the span till 60 months. Now the single dose therapy is again picking up very, very well. And concerned about safety profile, we have not seen many, no, not many at all. Might be just local redness, swelling, systemic I've not even seen, because we have been giving vaccinations since now long, and hardly anything. Might be synco, because that was also because if she was coming by fasting or something, you've given some fear factor or anything. Impact of screening and vaccination. We have to reiterate this fact that even though you're taken a vaccine, you have to come for screening. And that has proven beyond doubt that the impact of screening plus vaccination has given an impact value of 61% reduction in cancers. Screening, choose as per the resource setting you are. VIA, VILA, which is a government recommended one, a high resource setting. Like I have, we in our chain of, in our healthcare, we have chain of 35 centers, totally focused, working on preventive oncology part. And we have made one SOP that any lady walking into our center, now these are all rural centers also, try to tell them and give them lot of, counseling and awareness videos, try to promote to get an HPV test done. And very high resource setting, you can triage with various other mRNA or IHC tumor marker. So there has been a paradigm shift, you can see. PAP test, which has been usually done, but PAP is more subjective test, and being a specific test, it doesn't suit the sensitivity. It's not a sensitive test. Hence, you will find various false negatives. There was a Canadian study which said that, 31% of ladies who had full-blown cancer had PAP negative. So we have to be really very cautious, because one-time PAP is not going to give you any effects. You have to have a sequential PAP if you are fitting it into PAP testing as a screening module. But inflammatory smear again is the biggest challenge, and HPV being the main thing. No, HPV has a very fantastic way ahead. You have to understand one thing: whenever you're choosing an HPV, you choose those WHO validated tests rather than the lab validated test. Now, what are the WHO validated tests? Digen HPV, that is hybrid capture. Cobas is there, 4800, Service Tab. Hologic is there. And then you have various, guidelines how to go about with this HPV positive. Now, WHO guidelines is also fantastic. They are saying screen and treat, screen, triage and treat. And they have, you can go through the web page and get these things sorted out. And these are excellent. I mean, most of you would have heard me talk about individual algorithms and, giving examples to that. This is how we go ahead to show how to do this screen and treat and screen, triage and treat. Now let's talk about ovarian cancer. Now, ovarian cancer is also picking up. Now, you see, in the burden for India, it is 3.5% because of ovarian cancers, more incidences, and mortality 3.8. And we all know about the stages of ovarian cancer and the classifications depending on histopathology. Epithelial ovarian cancers are more common. And what are the challenges? The challenges is it doesn't have a pre-invasive or precursor lesion. Ovary is not accessible like cervix for direct inspection. And the risk of false positive, low prevalence of ovarian carcinoma. Hence, we forget, many times when the patient comes to us with a deceptive type of symptoms like, blenching, abdominal pain or fullness, we try to relate that to indigestion rather than thinking about, bloating, discomfort. We have to think now during this understanding in the Well Women Clinic, we better even think about this, that, ovarian cancers can occur. And I have been seeing, because ours is more focused preventive onco centers, we have been seeing a rise in ovarian cancer a lot nowadays. And, they come with all these vague symptoms. So something which we have to really, it should strike us is, when they say belching and bloating and feeling quickly full after eating and change in bathroom habits, we have to think about it. You do a general examination, pelvic, examination, sonographic examination, and try to assess. There has been a lot of lifestyle related factors also. So ovarian factors are more hereditary in nature. We all know that. I just told you about BRCA and BRCA2 and 1 and low. And so there are these screening methods for it. One is symptom index, one is pelvic examination, one is CA-125, one is TV sonography. Now with this GOF symptom index, you have this bloating, increasing abdominal size, feeling full, difficulty eating, loss of appetite, pelvic abdominal pain, urinary urgency, frequency, weight loss. If this persists for more than 12 times a month in a less than 1 year, this index has proven the sensitivity of identifying ovarian early cancers of 56.7% and at advanced stage of 79% with specificity of 90%. We have CA-125 as the only US FDA approved biomarker, which has a sensitivity of 83%, specificity of 59.5. Now, the only thing is it can be elevated in any, it's not specific, it can be elevated in fibroids, in endometriosis, menstruation, tuberculosis. And so what do? You do a serial CA-125, not only one, it has to be serial. So that increases the PPV value of 40%. So what is it? You have to see the area under the cover, which is called as risk of ovarian cancer algorithm. That's called as ROCA. And the studies have shown, UK studies have shown that ROCA alone could detect 87.1% of invasive epithelial cancers. Then you have sonography. Now limitations of TVS are what? Many a times many aggressive tumors metastasized even before we have understood it. And then subjective variations are all there. Poor visualization, many times hysterectomized, so we don't know, obesity. So you have these newer technologies, Doppler, photoacoustic imaging and all that. Now guidelines for screening in an average risk asymptomatic women. What is this US Force guideline saying? That ovarian cancer mortality did not differ between the screened women and those without screening. So these are average risk asymptomatic women. Rather, we did a lot of surgeries in which was not required. Now, what are the guidelines for the high-risk women? Genetic counseling, pre-test genetic counseling, post-test, and then you do those BRCA mutation studies and multi-gene panel index. And first with the index case and then finding it other. Then fertility preserving this thing like we just told you about BSO, RRSO in women and who have completed their family. And so hysterectomy, BSO for Lynch syndrome. So evidence of RRSO, that is risk reducing salpingo-oophorectomy, and their overall survival was longer in RRSO. And high grade serous ovarian carcinoma mortality was lower if we had done this, and also breast cancer mortality. Chemo preventions have been spoken about. OC pills are really very good. I mean, that's the studies, and aspirin in Lynch syndrome. Now, what they have said, why are they saying about tubal ligation? Because you can see this genetic chart, which is showing that invasive cancers, serous tubal intraepithelial carcinoma, which is called as STIC, STIC, is a putative precursor lesion to high-grade serous ovarian carcinoma. Hence, you do a risk-reducing salpingectomy. Then talking about other tumor markers, you have CA-125 for epithelial, CEA for mucinous, HCG for embryonal choriocarcinoma, inhibin A and inhibin B for granulosa cell tumor, LDH for dysgerminoma, and alpha fetoprotein for endodermal sinus tumor and embryonal carcinoma. So this is for diagnosis, for monitoring, it's very important. CA-125 alone, nowadays limitations are there. Hence, there are also sometimes false positives are also high in a premenopausal women. To cover these limitations, you have HE4, and that again, it is elevated HE4 are expressed in the early stage. That differentiates between your ovarian cancer and benign conditions. So HE4 for therapeutic monitoring and for giving it to oncologists. That's very important. as a biomarker. You should know when you do a Roma test, whether this Roma test, I can do it as a gynecologist or should I give it to a gynae onco? That is where we have to, and also the prognosis and relapse factors are understood. So this combination is now well studied and well documented. See the sensitivity and specificity. You have a Roma together, it has increased with sensitivity of 96%, specificity of 80% compared to individual. So that's very important. There are various studies related to this. And how does that work? Now that is like, it works on 3 parameters, HE4, CA125 and menopausal status. So this determines the risk of malignancy in a woman, whether it is high or whether it is low. So, and also increases the sensitivity and also the referrals. Now talking about many of us do sonography. So we should know a difference between the simple cyst and complex cyst. Simple cyst is round, oval, thin, imperceptible, wall, posterior acoustic enhancement, anechoic fluid, and absence of septation. Whereas a complex cyst is complete septation, multilocular, solid nodules, papillary projections, and resistance index, that is RI, is less than 0.5. Now you have, in an IOTA classification, you have B rules and M rule. Now, B rules are benign rules are urinocular cyst, whereas in M rule, it is irregular solid tumor. Solid components less than 7, here it will be ascites. Acoustic shadowing will be there in B rules, and here you will have at least 4 papillary projections. Then a smooth multilocular less than 100 mm, here that is irregular multilocular more than 100 mm. Low, no blood flow, very high, strong blood flow. This IOTA has shown sensitivity of identifying 95%, specificity of 91%, and negative likelihood of 0.06. So that's very, very important. Then you have RMI, which calculates your sonographic index score, menopausal status, and CA125, cutoff being 200. So RMI is something which we have studied for past 30 years. We are all practicing long, and we have been doing RMI and understanding of RMI and how do you take up these cases. Suppose in a postmenopausal ovarian cyst, a cystic lesion is 1 centimeter or more, you have done an RMI, and RMI is less than 200, that is low risk. Then what do? You just see whether the cyst is fulfilling all the criteria of asymptomatic, simple cyst, less than 5, unilocular, unilateral. You consider for conservative management. Repeat the assessment in 4 to 6 months. Again, you will do CA125, TVS, TAS. If it is resolves, fantastic. If it is remains unchanged, the same, the cyst is persisting, again repeat it in 4 to 6 months, and then individualize the case. And then if there is any changes, you will think about intervention. Now, if the cyst has any of these features like symptomatic, non-simple, more than 5 centimeter, multilocular, bilateral, you will think of doing a salpingo-oophorectomy, usually bilateral. Suppose if the RMI is more than 200, then what will you do? You will do a CT scan, refer to a gynae onco, have a MDT review. If the MDT review is saying likelihood of ovarian cancer, you will you do a full staging procedure with a trained gynae onco. If the MDT review is low, then you can think of TH, BSO, omenectomy, peritoneal cytology by a trained gynecologist. So then I come to the last cancer, endometrial cancer. Now, again, that's very low down, pretty low in the risk, but then the risk factors are late menopause, nulliparity, unopposed estrogen therapy, history of persistent anovulation, irregular excessive perimenopausal, premenopausal, also bleeding, obesity, diabetes, hypertension. Then personal history of all these, familial history, or typical endometrial hyperplasia, tamoxifen therapy, and radiation menopause. Now, if there are factors of increased risk in premenopause and postmenopause. So over here we have endogenous estrogen exposure, anovulatory cycles, PCOS, morbid obesity, estrogen secreting tumors, and hereditary. Now, HNPCC are also increasing on rise. Postmenopausal women, endogenous estrogen exposure, morbid obesity, estrogen secreting tumors, cirrhosis of liver, exogenous, where you are, giving tamoxifen or pelvic irradiation, hereditary syndromes are hereditary non-polyposis, colorectal cancer, BRCA1. What are the warning symptoms? Signs, they are irregular heavy postmenopausal bleedings, and abnormal, excessively, now there is more than 5 mm in a postmenopause, that is the endometrial thickness, and if it is menstruating more than 12 to 14 mm. Now, there are a lot of studies which has been shown, screening methods. There were a little bit of ambiguity between 5 mm and 4 mm, and then this is the sensitivity chart. And they have said that if you take it up at 4 mm as a cutoff point, then the sensitivity increases and specificity also increases. Now, whenever we are doing this formal hysteroscopy or endometrial curettage, only 65% of the endometrial cavity is actually being sampled. And they have seen that an endometrial thickness of less than 5 mm could indicate 1% chance for endometrial cancer compared to 10% risk in general population. Women on tamoxifen, yes, definitely, you will have to be more stringent. What is the American Cancer Society recommendation? Now, women with asymptomatic women who have Lynch syndrome or family history of colon cancers, they should be tested annually with endometrial biopsy beginning at the age of 35. Progestin should be added to estrogen and HRT. And women who are undergoing surgery for colorectal cancer and who do not wish to preserve fertility should be offered prophylactic hysterectomy and or oophorectomy. What is Lynch syndrome? Among endometrial cancers, Lynch syndrome accounts for approximately 2 to 6% of cancers. Now, Lynch syndrome is an autosomal dominant inherited syndrome, mainly caused because of germline mutations in DNA mismatch repair, that's called as MMR genes, MLH1, MSH2, MSH6, and PMS2. Mutation carriers have an increased lifetime risk of developing colorectal cancer, 40 to 80%, endometrial cancers, 33 to 61%, ovarian cancer, 9 to 12%, and other LS-associated cancers. Thus, it is clinically relevant to identify LS, that is Lynch syndrome, among EC, that is endometrial cancer, to predict and prevent other associated cancers. What are the recommendations for screening? Asymptomatic women, no risk factor, normal physical examination, routine yearly follow-up. Risk factors, you do a TVS. Tamoxifen use, do an annual sonohystogram. Genetic risk factors, do an annual endometrial biopsy, abnormal physical examination, transvaginal ultrasound. Symptomatic patients do an office endohysteroscopy and endometrial biopsy and transvaginal ultrasound. Dilatation curettage is if unable to perform office biopsy or abnormal ultrasound. Talking about all these things, we have not to forget lifestyle modification. Now, lifestyle include tobacco, alcohol, unhealthy diet. You can see this I've taken from the WHO paper, position paper, and which had said that, see, look at that, 33% is caused because of lifestyle. Tobacco, alcohol, unhealthy diet, 33%, infections, 20%, hormone, genetic, 10 to 20%, pollution, 1%, and occupation, 2%. So do have this modification in diet and supplementations, and balanced diet is something which really we have to think about. And we are all mainly on this path, but we have to really also focus on the above with the greens and proteins, rich diets have to be taken up. It has to be a balanced diet, mainly, which I say. It's not only, and nowadays with this fad of fast food and all, we have been seeing that somewhere the balanced diets are not there. And fruits and vegetables have to be included. Calciums with curds, paneer, and glasses of milk and cheese, again, has to be really taken up. And again, green leafy vegetables, iron, we all know about it, but how many of us are truly following it? That's very important. And again, water, salts, and all that thing. See, these are all we know. We have been telling to our patients, but I think even we as gynecologists, we as healthcare providers also should be following these tips of diets. So a healthy, well-balanced meal with a food pyramid has to be followed up. Exercises has to be really being done. You cannot ignore your body signs of overeating or not exercising, and very, very important. So I leave you all with a ray of hope that the prevention part is definitely very important, and today's world is moving towards prevention. So prevention definitely is better than cure. And I think Dr. Jairani, you have taken the wonderful topic today, and we all are really enjoying your conference, your webinar. Thank you.
Thank you, Dr. Priya. You have wonderfully just taken us through all breast cancer, prevention of breast cancer, endometrial cancer, ovarian cancer, and cancer cervix through in a very detailed manner. It was a very nice lecture. We enjoyed it too much. And we think we should all follow all these guidelines routinely in our regular practice so as to eradicate and eliminate cancer cervix and to reduce all the incidence of other cancers in women also.
Yes.
Thank you, Dr. Priya. That was a very amazing presentation. You made very crisp and very effective to take home messages for all our clinical practice, which is very useful. And I thank you so much. After a long travel, you had a day. I know that you just traveled and you came rushing. And thank you for accepting our invite and sharing all your expertise and knowledge in this content. And I'm really
One
proud to have,
question.
yeah.
Dr. Priya, you were telling about a single dose vaccination for HPV. You were mentioning. What is your advice regarding it?
As of now for India, no, please don't take it up. It has to be your double dose only. That is all being done in Australia and all that because they have already achieved their targets. So, but one understanding is, suppose, see, we get a lot of patients where they forget second dose. And our understanding should be that even one dose, this is after a lot of studies, in that even Parthas and Corcoritas trials were also there. They have shown that there is not a dip in the antibody levels. So that is one thing which made us understand. And that is how SAGE came up with the recommendation. But that recommendation is not for India as of now. Let that be very categorically understood.
Because the nanovalent vaccine is very costly. So if people can be given single dose, definitely it may go.
I understand, but this is not come in the recommendation. That's the main thing.
Thank you.
Yeah.
Thank you, Dr. Priya, for the wonderful talk. I think you just took us through the complete preventive measures for ovary, cervix, and then endometrium. Before we move on to the vote of thanks, we just want Emcure to show a few slides being the sponsor. Raji?
Yes, ma'am. Ma'am, am I on the right slide?
Yeah.
No, you should show your company slide. No.
Yeah. Thank you, ma'am. Thank you for allowing me once again. Ma'am, thank you for allowing us for your 5 minutes time. I'll not take much more than that. This is about a new launch which we are planning in Emcure Pharma. What is to be an EVA? So EVA means life, which is also means mother of life. Since you have been discussing about women, health, and so many things, and now the women are postponing their marriages and for planning of their child also, which has been a lot of discussion has happened. So we have taken the same theme for our brand also. It is like an Eva who is taking care of her education, career, and family responsibilities. Now we are launching an Eva to take care of the new beginning in life and to initiate the joy of pregnancy and to support her throughout the pregnancy. And now IVF have become a boon for all the women who are trying for pregnancy, especially in her late 30s. So with this note, I want to play a small video. So to support all the EVAs in their journey of gestation, we are happy to present you a Dydro EVA, which is dydrogesterone, especially for ART, especially in infertility we have made. And IVA feels so proud for partnering with you as an academic partner in the live webinar on preventive care in obstetric and gynec practice from the makers of Materna HMG, Dydro EVA and other brands. We would like to thank Dr. Jairani ma'am for giving us an opportunity and giving us this platform. Thank you so much, ma'am.
Now we move on to our vote of thanks. I request Dr. Kalevani ma'am, the Director ISO KGH and UG and PG teacher for the past conducted workshop and Best Doctor Award from the MGR University 2018, Chairman Board of Studies and Dr. MGR University and Honorary Treasurer in Oxy. She brings a lot of money to Oxy. Over to you, ma'am, for the vote of thanks.
Thank you, Dr. Kundavi. On behalf of Oxy, it's a great honor and pleasure to propose a vote of thanks for this wonderful webinar we had today. I immensely thank the organizers for organizing such a practical topic for the first webinar. I thank our chief guest, Dr. Jaideep Malhotra, for her introductory speech as well as felicitations. I'd like to thank our guest of honor, Dr. Lakshmi Shrikande and Dr. Yashodhara Prati for their valuable inputs. In fact, Dr. Yashodhara stressed on the importance of the commonest prevalent problems that we are facing today and how to go about in preventing this. I thank all our chairpersons, Dr. Satish Damankar, Dr. Manju Singh, Dr. Kamini R. Patel, Dr. Rajal Thakur, Dr. Radha Tatukudi, and Dr. Premalata for being the chairpersons for this program and interacting with the speakers as well as giving us salient points. I like to thank the speakers, mainly Dr. Manoj Chalani, who dealt the first topic on preventive care to improve obstetric outcome. He dealt almost all the preventive aspects in obstetrics, right from giving medications, the psychosocial aspects which we usually do not deal with, and regarding the preventive aspects, particularly in obesity and diabetes, which is more prevalent in our society. And he also stressed upon the genetic screening as well as vaccination and environmental toxins. All these things had to be dealt if we want to have a good outcome. The second speaker, Dr. Sunita Tandalwadkar, who also spoke about the steps to prevent infertility, right, starting from age to what are all the things that has to be done to improve fertility in our society. And I also thank the last speaker, Dr. Priya Ganesh Kumar, who also talked about all the cancers. In fact, she touched all the practical aspects of cancers, how to prevent them, what is being done in the society, and what are the steps that has to be done in future to prevent cancers. And great importance was given to vaccination. In fact, Tamil Nadu has been chosen as a state to prevent vaccination, and we are going to roll this project, and maybe in future, all our children or all our girls will be vaccinated. And I also thank all the delegates who stayed till this end, though it was extended for another 45 minutes. I think most of them had stayed, and I think they would have got valuable points for practical purposes. And I last but not the least, I like to thank Emcure Pharma for organizing such a wonderful webinar. And I thank once again everyone who stayed tonight. Thank you.
Thank you, Kalevani. Thank you so much. And we are all very happy to have everyone here. And I thank all the senior faculties, our professors, and all the chief guests, everybody for being with us. A very special thanks to Rajeshwari and the Emcure team.
Thank you, ma'am.
And Emcure team, Mr. Indra Kumar and others for making this a wonderful platform to communicate and to educate. Thank you for your participation. And
thank you, ma'am. It's our pleasure to be a partner.
Okay. Good night, everyone. Good night.
Good night, ma'am.
Good night.
Thank you, ma'am. Thank you for the opportunity.